But in the meantime, I could say one or two things about eclampsia, and how we look at it, but also in regard to how we look at the blood rounds as the department and the other members of the project, that it is a very big, it's one of the areas where we can get as much information as possible, more than anywhere else, and that's what we are expecting. There is what we are called the big five. In Africa, we have the biggest 5 animals. And when you look at this, it can be related to the big 5 causes of maternal mortality. If you talk about the big 5, you only have things like unsafe abortion, obstructed labor, okay, then hemorrhage, infections, and then you have the hypertensive disorders. So if you think of these other big 5, then you also think about the 5 killers of our mothers. And basically, what does this mean? That if you have a patient who has any of these conditions, a lot of effort must be put in. Otherwise, if that is not done, this reality includes this mother. One of the biggest ones is what we are discussing today, eclampsia, and of course, how can be complicated by eclampsia. So it is a very important topic, and it has continued to take away a number of our mothers. We have seen science develop from when we were managing these patients in the lower level, 5th floor. At one stage, patients who had the hypertensive disorders would be managed in double rooms. Like they have X-rays where they read them in the medical room. So later on, science indicated that this was not necessary. At another stage, if somebody was showing signs, that time we call it eclampsia, maybe we have it now with the severe features. They had some combination of drugs. It was called the elephant mixture. Yes, so they will sedate the patient so much that they don't think you can get the patient is not able to breathe. And that's why you see the issue of the big 5 is so important. So we have developed so much to the extent that now all this has been eliminated. We have now organic drugs. And we can, even the science is being understood more in terms of the pathophysiology, pathogenesis, and that is really very good for us. The other thing as people who are in reproductive health care, we need to manage this patient. If somebody has eclampsia, make sure we sit there and manage the patient. I can put this in context that we have a head of department whereby a patient reported on duty and the convalescent and the possibility was not around. And this patient got complications. When the chair of the department, like our officer here, had a meet, they gave a very severe punishment. And that stage was taking it for a whole year, taking the course, repeating it. Because you know now, things are being done right, but it shows, I just want to show how serious it is in terms of the way we should manage patients. That when a patient is very sick, we should make sure we put in as much of our effort, as much of our time to save mothers. And because you know that, for example, in the one there is laxity, you can even have 5 maternal deaths on the same day. So members, let's continue to be vigilant. Some of the people they don't like it because things are a bit easy. You press this and something happens. The other one I will say, the last one I should not say too much, but one of the ones I learned when I was reading about eclampsia and eclampsia, there was one called scotoma. I was reading Johast, postgraduate book for Obstetrics and Gynecology, and then that was one of the points that they were talking about. That is, people can see some blind spots. Visual, so when we talk about visual disturbances, what are we meaning? Apart from the many other visual disturbances, but this is one of those which I was learning as a new one, and I was already a postgraduate. Maybe I should have that. So for that, the condition is very much really remembered. Of course, now these are now common ones. So members, it's a very important subject. They tell us the figures in terms of how much it's still costing. Maybe depending on your source, 68%, and so many deaths globally. So I hope we will be online soon so that you can be able to listen. Are we on now? Oh, excellent. Remember that we are now on. Actually, I connect as I was coming and was coming in. So we should progress with the program, and I should also know to present the case that was very good presentation. But next on the program, we'll have one of our colleagues, Professor Paul Chiono, is the senior person in the director of Obstetrics and Gynecology, but there are also some specialists. These people to that research, and let us welcome Professor Paul Chiono.
Good afternoon, ladies and gentlemen. Today we are looking at the Eclampsia. Remarks are already been made. So this is the outline of what I'm going to go through. And pre-eclampsia complicates 8% of all pregnancies worldwide, but it could be higher in low and middle income. Oh, is it? The other saying complications 8% normal pregnancy worldwide, but could be higher in low and middle income. With other hypertensive disorders, what they do maternal mortality. Second, to PPA. It's responsible for iatrogenic prematurity and also contributes significantly to neonatal morbidity and mortality. And has been estimated that up to 3% of preterm births are due to preeclampsia. Worldwide, about 50,000, 60,000 preeclampsia-related maternal deaths are reported annually. Some statistics in the US say that preeclampsia has recently increased by 25% in the last 2 decades. I don't have our statistics here now. Okay. Preeclampsia is a pregnancy-specific disorder. It's associated with new onset hypertension and new onset proteinuria after 20 weeks of pregnancy. In absence of proteinuria, new onset hypertension associated with end organ dysfunction can lead to the diagnosis of preeclampsia. It resolves after delivery of the placenta. However, women preeclampsia increased risk of future cardiovascular disease. The diagnosis depends on hypertension and significant proteinuria. A systolic hypertension, systolic blood pressure of 140 millimeters of mercury or more, or diastolic blood pressure of 90 millimeters or more. On 2 occasions, 4 hours or more apart after 20 weeks of gestation, in a woman with previously normal blood pressure. That interval should not be more than 1 week. 4 hours, not less than 4 hours, but not more than 1 week. And significant proteinuria, which is 300 milligrams of urine in a 24-hour urine collection, 300 milligrams or more, or protein creatinine ratio of 0.3 milligrams per deciliter or more. In absence of this, you can use deep secreting or true blood or more. Preeclampsia with severe features. We consider systolic blood pressure of 160 millimeters of mercury or more, or diastolic blood pressure of 110 millimeters of mercury or more. And this one should be confirmed in a short time facilitated. There are also other end organ involvement, like impaired liver function, where you have ALT and AST twice the upper normal, or patients who present severe, persistent right upper quadrant gastric pain, thrombocytopenia of less than 100,000 per deciliter, renal insufficiency, serum creatinine of more than 1.1 milligram per deciliter or doubling, pulmonary edema, new onset headache or visual disturbances, fetal growth restriction, with estimated fetal weight less than 10 percentile. Of note, proteinuria is not a diagnostic feature of preeclampsia with severe feature. We used to use 5 grams or more, but no longer a diagnostic feature. Then you have gestational hypertension. This is where hypertension without proteinuria or severe features develop after 20 weeks gestation, and the BP returns to normal after delivery. The systolic blood pressure is 140 millimeters or more, millimeters of mercury or more, or the diastolic blood pressure of 90 millimeters or more, on 2 occasions, 4 hours or more apart after 20 weeks gestation. The woman with previously normal blood pressure. We also have severe gestational hypertension when the systolic blood pressure is 160 millimeters of mercury or more, or the diastolic is 110 millimeters of mercury or more, and should be confirmed in a short interval. When proteinuria develops or end organ involvement develops, then diagnosis of preeclampsia with severe feature is made. This is a classification, it's a very old classification of 1972, but it helps us to understand the different hypertensive disorders in pregnancy. We have preeclampsia, gestational hypertension, we have chronic hypertension. This is pre-existing hypertension, which is there before the woman is pregnant or diagnosed before 20 weeks. Then you can have preeclampsia, superimposed chronic hypertension. The others are not included here, like eclampsia and which you are going to look at later. So eclampsia is a comprehensive manifestation of hypertensive disorder and among the more severe form of manifestation of the disease. It's new onset, tonic, chronic, focal or multifocal seizures in absence of other causes, like epilepsy, infarction. It's a significant cause of maternal death, especially in low and middle income countries. Seizures may lead to hypoxia, may lead to trauma, may lead to aspiration pneumonia, although the neurological damage is there. Premonitory signs are there in most of the patients, but in some cases they may not be present. Of note, only 1.9 patients with preeclampsia and 3.2% patients with severe preeclampsia develop eclampsia. You know that all patients who come from preeclampsia with severe features and end up in eclampsia, not all. It's only a small proportion of them who develop the eclampsia, but we must be on the lookout for those who are likely to develop eclampsia. Then you have the hemolysis, elevated liver enzymes, and low platelet count, the health syndrome, the manifestation of severe forms of preeclampsia, and is associated with increased rates of maternal morbidity and mortality. The diagnosis is made when there's elevated lactate dehydrogenase, more than 600 micrograms per liter. That's what the transaminase and other transaminase more than twice the upper limit of normal, and platelet counts of less than 100,000 per liter. Mainly, it's a third trimester condition, but 30% of the cases may occur postpartum. And in some cases, may have an atypical presentation when there's no hypertension or proteinuria in about 15% of the patient. Present upper foreground pain, general malaise, nausea, and vomiting. Etiology of preeclampsia, this is analog, not the etiology for the cause of preeclampsia. But we know that the placenta plays a role. The liver of the placenta reverses the syndrome, and the liver of the fetus alone. There are some cases the fetus alone and leave the placenta behind. When the patient has preeclampsia, the symptoms not resolve, not improve until the placenta is resolved. So the placenta is important. Preeclampsia is due to abnormal placentation. The situation, there is an adequate plastic inversion of the spiral arteries, so that the vessels remain massicular, narrow and responsive to pressure agent. This leads to placental ischemia and release of factors in maternal circulation, which are bring about the inflammatory process. Again, endothelial dysfunction, which is a hallmark of the disease. These include the fascicular growth factor, endocrine, the inflammatory cytokine, and then cytoplasm microparticles, among others. Not all patients who have abnormal placentation end up developing preeclampsia. So there are those who are at risk. There are factors which make some people at risk. And there's a genetic predisposition, like in the past relatives. There are also immunological factors, like the immune maladaptation. Because a fetus is kind of an allograft, it's a semi-allograft, because it's got a paternal component. That's why you see it in prime gravida, but in subsequent pregnancy, it's reduced. Even sometimes, even they have seen that miscarriage is also when someone has been exposed to the paternal gene at some point. Prime paternity. Prime paternity here meaning change of spouse. That women at some point they change a spouse, and especially if that spouse has fathered a preeclamptic pregnancy. Long cohabitation, pleasure disappear. Long cohabitation. If people have been together for a long time, they take time before they have the first pregnancy. If they're not using barrier methods of contraception, then that's also have seen been seen protective. And then egg donation is a risk factor. There are also other issues like oxidative stress, which has been seen. Come back by say. Like obesity, maternal susceptibility, like medical diseases, chronic hypertension, diabetes, obesity. These women tend to have some level of oxidative stress, and they are at risk. They are pregnant and with abnormal placentation to eventually develop preeclampsia. I wait. Yeah. what it shows a picture denoting the placental changes, but I can see, but you cannot. Not for me. For you. Probably I can continue. There is factors fetal, maternal, and fetal. We are not saying I can continue. I think we are of maternal or fetal. And one of them is age 35 years or more. In prime gravity that increases, and we are also seeing that in multi-gravida, 5 or more. The books or literature says only prime gravity are those where they have 1 or 2 children. But like in our situation here, where we have many children, places like India, places Southeast Asia, Latin America, then there is multi-gravity found out that. I've talked about primary paternity or change of spouse, pre-existing vascular disease like chronic hypertension, diabetes, kidney disease, family history or preeclampsia or gestational hypertension or past history. We've seen situation of antiphospholipid syndrome and phospholipid syndrome. I'm not saying this right now. And obviously, BMI of 30 or more than 30. They also there are also fetal risk factors, multiple pregnancy, either more, or some people call it molar pregnancy, such as ISO immunization, and assisted reproductive technology. Mr. Chair, I submit.
Thank you very much. Thank you very much, Prof. Chiondo. Welcome over there. Thank you for the also simplified so many aspects.
You didn't know the audience.
There is something called placenta specific. SFT-1. It's coming up so much in the Eclampsia. So we have the next person who's going to present to us our professor. I hand that to you. He's also a member of the senior leadership team of NASMEC, and currently more politically she's dean of School of Thank you. Good evening, everyone. Apologize I'm working late. Another critical meeting started early in the morning. Taking look at the dermatosis, cyclans, and diabetics others, why they are at increased risk of getting preeclampsia. And every other issue should be able to explain why some individuals are genetically predisposed. Now, there are not so many theories that can explain that, but one of the favorite, and I belong to that group, is the one regarding defective placentation.
We now know that after over 300 years of the existence of this disorder, that in majority of cases, we think the problem is effective placentation. And I would just like to use this diagram, which I have permission to use from Ashley Moffett. She was my PhD supervisor at Cambridge. So I have permission to use whatever she wants me to use. And this diagram is actually published in Nature Reviews. It nicely illustrates what the differences are when someone has what we call remodeling of the spinal arteries, has gone well, and the comparison with the non-pregnant woman, and then we see what happens when things go wrong in preeclampsia and other disorders of pregnancy, which we call the great obstetric syndromes. So normally, when someone is pregnant, we expect that physiological processes immediately start happening at the CT. One of the critical ones is that these spiral arteries, which by the way are the end arteries for the uterine arteries, they have to be remodeled by the extravenous trophoblast such that they are able to increase their capacity of blood supplying blood flow. So that process done by the extravenous trophoblast is very important, and we believe it should happen in every woman. But for some reason, it doesn't happen as adequately as it should. Sorry, I don't think that. But if you see the non-pregnant woman, the spiral artery is really tortuous and that common problem. But once she gets pregnant and things are happening as expected on the father side, you'll find that these extravenous trophoblast, those funny things like small animals with eyes, they try to remodel both the inside and actually the outside. And this they do both, believe is done both directly, but also indirectly through what cytokines are being produced. So we then end up with a vessel, which is wide, and that has advantages. It facilitates the placental blood flow, and in addition to that, that ensures that the blood flow is gentle, so turbulent. When you have a high volume vascular veins, there's a tendency to have turbulence flow, which is not really good for the growing embryo and later fetus. So this is one of the big things that everybody agrees on in the preeclampsia about, that in the majority of cases, we are having probably some of these remodeling only going as far as the residual layer, and not going beyond the 1/3 of the myometrium. I'm trying to indicate the different layer. So we feel like for it to be adequate, it should go at least the middle layer of the myometrium. Something beyond that, or before that, then that's inadequate, and beyond that, we don't want it, because that's where we end up with placenta, preta, and other abnormalities of placentation. In other words, this process is really regulated. We don't want it to be too much, such that the placenta just goes and goes through the myometrium to the peritoneal cavity. At the same time, we want it to be adequate enough to be able to provide nutrients and also clear our products from the fetus. Next one. So, by and large, another thing we always also agree on is that this disease is actually a two-stage disorder. What I've described is really the placental phase of the disease, whereby we have poor placentation being the culprit. After that first stage of the disease, the next stage is what we call the systemic inflammation. This is what manifests in the mouth. And this happens not because of the defective modeling that happened in the uterine spiral arteries. No, because that is the confusion many people have. This is happening because that placenta, which performed poorly, gets ischemic, if I will call that one, and then starts producing certain factors in the very old textbooks. I remember there's a young used to teach us. Also called factor X. Factor X, just be aware that it's not likely to be one factor. There are several candidates. These are produced by the placenta because as the fetus grows, and usually about 5 months, the placenta starts getting overwhelmed. It can't meet the fetal balance. So it produces this, and the suspects include free fetal DNA, placental debris, those unfolded proteins, and also, of course, there's excessive production of what we call the anti-angiogenic factors. Soluble fluid is one of them. That's linked to CSFMT. And then, so this soluble fluid is produced in excess for the preeclampsia placenta in comparison to the vascular endothelial growth factor. Now, these soluble fluids and vascular is a soluble receptor for vascular endothelial growth factor. I hope I'm not confusing you. But it's not a good one because it actually competitively inhibits binding of the good vascular endothelial growth factor on its, what I would say, genuine receptor, and making it unavailable. Vascular endothelial growth factor is important because it is responsible, it's called a pro-angiogenic factor. It is responsible for vascular formation, forming new vessels and repair. A process which is very important in the placenta. As you know, the placenta is a very rapidly growing organ, but also this happens in other organs in the body. So we see that in preeclampsia, you have more of this factor, which is anti-angiogenic, does not provide properties for formation of new vessels and repair. Instead, you have a dangerous soluble fluid. So basically, those factors and others are not mentioned here. Then they find their way into the maternal circulation, causing another what we believe was the cardinal point of pathophysiology of preeclampsia, causing widespread endothelial dysfunction. I'll summarize this, you don't have to worry about it. So we've seen, again, emphasizing that this is a two-stage disorder. The second stage usually is what we see when the patients present to us. And of course, the other things on top here, what is really the blanket different theories are trying to explain. And again, emphasizing that probably placentation is not a standard theory. It depends on someone has to have genetic predisposition to have inadequate placentation. And I'm going to illustrate that in a while. Or could actually be an immunological imbalance that makes her not be able to really have the placentation happen as adequately as it should. Whatever the case, once we have effective placentation, then we get the stress, as I earlier said. Then we get these many abnormal factors, the mother. So the disease has moved away from the placenta to the mother. She starts experiencing effects of abnormal endothelial function. Endothelia lines almost all vessels, in fact, all vessels in the body are many. So you can imagine, everybody has endothelia and their abnormalities, then you're likely to have manifestation of preeclampsia. Now, also there is some endothelia which is more prone to some of these factors. We know that it's described as fenestrated. This is the brain, the kidney, the liver, and the coagulation system. And because of that, those are some of the diseases where we see, when the organs now we see most of the disease manifestation. Not that it doesn't affect the other endothelia as well. So endothelia really is regulated. When it is normal, there is what we call homeostasis. Things happen as expected. Where you have, for example, regulation of fluid between the intravascular and extravascular space, ions, where you have the smooth muscle lining this endothelium in a state of tonic relaxation, meaning you have these vessels in a relaxed state normally. Now, with preeclampsia and reverse happens, you end up with other abnormalities. For example, because you're not really able to properly regulate the ions and fluid between the intravascular and extravascular space, you end up with edema. You end up with platelet aggregation, because actually damaged endothelium favors platelets to aggregate. And when you have platelet aggregation, you also have a risk of blockage of arteries, especially the small ones, and these really supply major organs like the kidney. The other thing that happens when there is endothelial dysfunction is that you have widespread vasospasms, and that constriction is partly related to why we have hypertension, but also it has other direct effects on the RAS, the renin-angiotensin system. In fact, in preeclamptics, it's believed that there is no downregulation of the angiotensin 1 receptor, which should occur in a normal pregnancy. So they respond to all those factors in the woman's circulation, which would bind to the angiotensin receptor, compounding hypertension. So I've already talked about the coagulation abnormalities, cerebral edema, and the other abnormalities. So I would like to just summarize by saying the two studies sort of helps us to understand several things. That when we are dealing with preeclampsia, the problem started happening at the time of implantation, and that we have to be aware of. Because it has implications as we try to devise treatment and prevention strategies. And go to the next slide. Also, some of the advances are now, it's very clear that the extravenous trophoblast, what is facilitated by what we call the citonutrient cells, natural killer cells, to facilitate this remodeling of spiral arteries. This is a real diagram, colorful as it looks. And what you see as predominantly green are the deciduous cells, and red is really the placenta. Now, it shows you that there is a lot of residual cells at the time when implantation is happening at the first weeks of placentation. And that is not by mistake, because we believe they actively get involved in remodeling, assisting the extravenous trophoblast, and they also produce cytokines and facilitate the process. But in addition, we now believe that these uterine NK cells can be good or bad, depending on what the woman's genetic makeup is. If they are bad, then she's likely to face challenges in that facilitating that process of remodeling, and ending up with vascular, effective placentation and thus preeclampsia. So what we've done here elsewhere, I just wanted to highlight, we've been able to now isolate some genes, they are natural killer receptor genes in women here in Uganda, which actually protects them against preeclampsia. We simply call it the 2ds506 gene. I want you to appreciate that this gene is in the mother, but it interacts with the placenta nigricans, which is of the fetal origin. Once it does, either facilitates placentation such that the modeling goes as far as we want it, or the combination may lead to effective placentation. Now, I'm showing this to give hope, because we are now having very good understanding of the etiology of preeclampsia, and that is informing a lot of prevention strategies. I don't know if we slide after that, because if you've had, I think it will be talked about, one of the biggest prevention strategies that is looking at is low-dose aspirin. Now we know that low-dose aspirin, the timing is important. It shouldn't be very much within the second trimester. That is too late. It's already ongoing. The other issue we appreciate now is that there's a very strong genetic contribution from the father. This ligand, which does bad things when it interacts with the mother's receptor, is actually paternal origin. The mother's ligand, because the baby has the mother's and the father's. The mother's is always nice. She recognizes it. But the father's is what actually leads to effective placentation. So as we are looking for risk factors, we now move beyond looking at the mother. We are looking at the dangerous smell. Subject, the dangerous smell has a problem with the ligand, the HLC, that contributes to the fetus. And because of that, there are now very well documented studies, usually these are in the Scandinavia where pregnancy comes, which show that the following men, I want to emphasize the research on those points. Are there as well? One, those where a woman gets a child with pregnancy with, and they get pregnant when they do get it. Those are dangerous. The other ones are those who every woman they might get pregnancy. Are those whose mothers got pregnancy when they were expecting them. So this is going to I think you should be about this development, not that you want to stress out their counterparts. Is that actually it is well recognized that usually problems that affect men, solutions are quickly solved. So we are going to make these discoveries with the hope that we shall now accelerate our capacity, finding the etiology, information strategies, and the treatment. And ladies and gentlemen.
Thank you very much. Of course, what's that one that I'm going to make it fight so that they have but what we see that it's very important, we look at the breast, is that yes, I'm going to talk about things which are written in textbooks, but good enough today, we talk about those sources who have participated in the work. And as far as Makerere University is concerned, as far as Uganda is concerned, these are being developed. Because it means that we are developing. So we need to keep that up. I can see the should going to the next one. Now, Dr. Musa said, you know, some people call them chairs and others call them HOD, but one of the most important things, even as we look at the university, is the party. Even for this particular one, we have the first set kick. We can go ahead and have a grand round. Now, you say this.
Thank you very much. Sometimes I say, sometimes I just hope I was secret. I don't know about my presentation is going to be the things and there are two take-home messages. The first slide is the presentation. Just as can I say? The leveling of the syndrome. Okay, since wrong theory, then just not enough. The next thing is the presentation can also be as confused and the syndrome as the theory themselves.
So what we have as a presentation of eclampsia is not make response, there is no particular symptom, there is no particular presentation, which would say if you have this stage, exactly how eclampsia, or you are moving from eclampsia to severe features, or you are moving from severe features to eclampsia. There's nothing like that. The only thing which you have to keep watching out about the presentation of eclampsia is to have a high index of suspicion. And apart from that high index of suspicion, you also actively look out for what the patient presents with. Do not ignore a headache. Do not ignore, that's how pregnant women are usually. Do not ignore this. It could be some. Do not ignore a certain form. It could be unfamiliar presentation of another thing. So don't say that this. If you have headache and yellow malaise and your feet are swollen, that's what you want. You do not have such things. You don't have a plan, you don't have a program, you don't have a diet, you don't have anything. Equals paper. The presentation is usually mixed, like especially now setting the headache which someone presents with, they need you to the commonest one is one. And maybe we are women developing the symptom of malaria during pregnancy. So you can say, oh, the headache is anemia, let's give you treatment. The headache can also lead you to malaria. Maybe recently you can add it over, but that is more common in pregnancy. For the sake of that is, still that is something which is not pathognomonic for eclampsia. Straight from the which can occur. Included because of other problems, not specifically eclampsia. Nausea and vomiting, nausea without vomiting, still this is a common symptom of concentration during pregnancy. But if it extends into the later part of pregnancy, going into the second and third trimester, please don't ignore and say, oh, maybe you had spices. That's why you're being it. You have to have a high index of suspicion. Now, there is also a symptom which is not very good in our setting because we tend to have different positive connotation about it. If someone came to like, what do we say? Agents. Yes, sir. Excessive pregnancy during pregnancy is not a good sign of pregnancy. Actually, it could be related to the presence of eclampsia. So the bottom line in that sign, the symptoms, yes, maybe there, the presentation may be there, but the important thing is to have a high index of suspicion. We have to screen. Only suspecting that someone is having a headache, not taking the blood pressure, is not enough. And it's all too common that some of our dental clinics that big machine work for 1 week and they collapse. And the woman comes to the clinic, no blood pressure measurement, no deep sleep, and you think we are doing and then okay. And they don't know what we say. I want them to get company to change something percent. Yes, but the question of what you have offered also takes a lot. How many of those have you missed? We would have actually picked and formed in the process. We have like the okay aware the history is structured, but then many things are missed in the history. Someone comes to and they cannot even sprint for the heading of that patient. And then we just see them on the conveyor belt until they convert. That's the first time we say, oh, there's a problem. What was the use of that dental care when we could not pick out the salient features we should have said? This particular patient and that's slide 1. Slide 2. Slide 2. Still, you can read whatever is there, but the important message in slide 2 is let's actively seek out the possible complication. We have known the previous presentation that Eclampsia is a multi-organ disease. There is no organ in our body which doesn't have a blood vessel going to it. And if we have a vascular endothelial dysfunction, it means you are causing some damage to the tissue which is receiving blood. It could be a clot forming within the vessel. It could be a bleed occurring in the tissue. Any of that two, but we are compromising the functioning of that particular organ. So we will have symptoms based on the complications that are secondary to the involvement or the damage of the vascular endothelium. Prof. Which was talking about spontaneous. Sometimes women get pain in the muscles and say, that's muscle, ask your husband to massage you. Like 56. So let's be vigilant and look how active the program. It's really unfortunate that we not even do what the platelet counts with these women who have secondary and elevated blood pressure at week 24. Can we do a complete blood count and look out for the platelets? If they are within range, okay, let's continue observing. Someone is having a headache and you said, it is coming from the spinal cord you had during previous pregnancy. Last time I had spinal, I think it was bad, and even the doctor was affected. Since the headache is possible due to the spinal from the previous pregnancy. But if we not actively look out for these complications, then it's not possible to pick out or to really remedy and intervene the cycle function. Renal function. The kidney is one organ which can suffer a lot and also cause the entire body system dysfunction if it suffers thinking. We have seen that there's leakage of the income of the plasma from the intravascular compartment to the extravascular compartment. So if that also happens, that kidney will have a possibility of acute kidney injury. What's the cost of this? Maybe some people know. It's not little money. You might think going for 2 million shillings per day. The intensive phase. And if we do that for 14 days, I think none of us can take their wife for dialysis. Maybe very few. So these are things which you must actively. I even recall with my students, whenever I don't know in the severe they have done a complete plan of platelets are 90 and they have said that. They also go a step further, do the function tests, and they cannot even compute the estimated global nutrition rate. So how are we able? These are supposed people money. They are given they will do and you cannot make a test and take out. We have active look out for the complication and mitigate them in time. Liver function. If someone gets liver cirrhosis and by liver transplant later on in life, how many of us are for the liver transplant? Maybe very few. You might have to ask of the main way. So let's, for the pregnant women who can throw our hands, let's get active. First, we have a index of suspicion for the symptoms, and the second message is actively look out for the complication. It means we have to investigate our patients, how to investigate their renal function, their clotting time, their kidney function. And we also have to not forget that we are dealing with a pregnant woman, and there are possible complications of that particular condition that will affect the unborn baby or even that baby later on in life. So let's not celebrate that. Oh, this baby of 1.8 kilograms is going to survive. The mother is fine. There's a risk of enterocolitis. So don't say you better have baby, but the baby in the placenta is out, the mother is stable. Like had done say, oh, our patient did very well after delivery of placenta, and we were very excited because the placenta was downstream complication. I think I've said enough in 5 minutes.
Have something for housekeeping. Secretary and housekeeping information.
Thank you, Professor. Thank you, presenters. We are going to have a working refreshment, but just pick your food quietly as we give it to you and eat quietly.
Thank you very much. It is great to So there are members who have arrived and we need to the presentations, we answer questions. Professor Chiondo, the people who have arrived and we answer some of the questions. For the others, we have questions and comments so that we have a section for discussion where we will have an exchange of ideas. Critically, it's very important that we try to match from the presentation done by Professor Chiondo, epidemiology, pathophysiology, and implementation. But once you can understand this, you manage the patient, you can understand why patients develop. For example, something like we are moving to another section, and that is to do with the investigations. Yes, Dr. we are very much welcome to take us through. She's a senior member of the Department of Obstetrics and Gynecology.
So I'm going to go through the investigations we do when we have a patient suspected to be having preeclampsia. So we do these investigations first of all to confirm the diagnosis, secondly to see how I think you remember from Professor Chiondo's presentation, he gave us a classification. So these investigations help us to see how severe preeclampsia is, and also to plan management. So, for women who have new onset of hypertension, we do routine tests on them. And as we've seen from Professor Nachimuli's presentation, the pathogenesis, we've seen how preeclampsia affects different organ systems, and the worst affected ones are the hematological system, the renal system, and the liver. So the routine tests we do include, first of all, a complete blood count. And in a complete blood count, the parameter one to look at is the platelet counts. They could be mild or moderate or severe thrombocytopenia. And we also look at the hematocrits, whether we have hemolysis or hemoconcentration. Then when we look at the liver, we look at the transaminases. The ALT and AST, they are increased in conditions of preeclampsia. Then we look at the renal function, serum creatinine. Normally, the renal function in normal pregnancies, the glomerular filtration rate is increased and the renal blood flow is increased. So this causes creatinine and uric acid levels to be lower. But in preeclampsia, there is a reduction in glomerular blood flow. So there is increased creatinine and uric acid levels. Then we go to urine proteins. Urine proteins are increased, but we saw from Professor Chiondo's presentation. Sorry, Professor Chiondo is so humorous that sometimes when you're talking about him, you want to laugh. So when I was recollecting his presentation, he told us that proteinuria may be present or may be absent. So we can go to the next slide. So these additional tests may be done if we suspect HELP syndrome. And this is serum lactate dehydrogenase. It's normally increased in conditions of hemolysis when the red blood cells are destroyed. Then we could do a peripheral smear. They are normally abnormal shapes of the red blood cells, and this can be seen on a peripheral smear in cases of hemolysis. Then indirect bilirubin is increased in cases of HELP when there is increased hemolysis. Then coagulation profile, the utility of this is unclear, especially if the platelet counts are not severely reduced, and if there is no placental rupture or other complications of bleeding, we may not need to do a coagulation profile. Then imaging studies. This CT scan or MRI may not be necessary for this condition's diagnosis or management unless if there is sudden onset of neurological signs like severe headache or convulsions which are not responding or a typical presentation for eclampsia. Ultrasound is necessary to monitor, as we will see in management. Dr. Drum, I think, is going to take us through that, where you may opt for conservative management. We need to do antepartum fetal surveillance. And we need to use the ultrasound to assess fetal status and evaluate growth restriction. A cardiotocograph may also be necessary in cases of severe preeclampsia, where you want to monitor fetal well-being on top of the ultrasound scans. And as we see in features in presence of severe preeclampsia, we need to do some of these tests daily. And I think Dr. Groma will take us through that. I won't go there, but we may do some of them. We may need to do some of them daily and monitor because some of them change rapidly. For example, we looked at a complete blood count of cytopenia. The platelet counts may change so rapidly and we come to levels which are dangerous. And I think we will look at that. What are the dangerous levels of the platelets when the patient is no longer safe and can get intracranial bleed? So we will see that. Then there are also screening studies, but I think it's Dr. Antio is going to take us through this. Screening studies, when we look at prevention of preeclampsia, what do we do, what tests do we do to screen at-risk women so that we can do some of the prevention. I think Professor Nachimuli mentioned low-dose aspirin, some of the preventive measures. These screening tests, Dr. Antio will be taking us through them. So those are some of the tests we do. I think my slides end here. These are some of the tests we do, and it's important for us to know how to interpret them and to know when do we need to act and when it's no longer safe for the patient to continue on conservative management. So I will hand over. Thank you so much for listening. I'll hand over to Professor Kambishi.
Thank you very much. Another is there are some basics we have in medicine, which we feel we really need to share. And one of them is HIPAA, inspection, palpation, percussion, and auscultation. Usually say some people times one time before they see. Now I am reading this. The other basic one here is history, examination, and investigations. How we make a diagnosis. Remember, this comes up quite a lot, but always remember, hey, history, examination, investigation. Then you can say, now I have a diagnosis. Before you have some, maybe you may have taken enough history, examination, but you may not have done investigations. At times you can't be very sure that you have a diagnosis. So this, we need it as doctors, as people who see patients. Now here we have Mother syndrome. I remember say, you know, Mother syndrome when he was being postgraduate, he doesn't even know, but one time we were passing here, and we used to see him in this, on some of those chairs. He would be either resting or reading. So we were very happy when he was recruited into the university service. He really likes books. So what is you are very much welcome.
Thank you very much for your visa. I eat food, I don't eat books. But books are part of my life. So, I'm going to take us through the management of Eclampsia. I think maybe for us who have not read so much, this might be more interesting to us because you need to translate this complex pathogenesis and pathophysiology of natural, given us to help a patient. You are not going to split SFLT to the patient, but you will have to prescribe a drug or you monitor blood pressure or you deliver it. So this session should be a good one for all of us. I want to change it because I have forgotten my slides. So, probably we all know that when we are being taught preeclampsia, they used to tell us there are 3 principles of managing preeclampsia. And today I want to add two more principles. We're always told that the first principle is to prevent or control seizures and to control or manage or treat hypertension and deliver the baby. But today I want to add us that those two, that is the post-delivery or long-term follow-up and the prevention of recurrence, should be our goals of managing these matters. Because it does not stop at delivery. Much as we say, once we deliver the placenta, the disease resolves. That is not true for everyone. A big percentage of mothers end up with long-term complications, which I will talk about, because there's someone who's going to do that. So our first goal of management is prevention and control of seizures. For long, magnesium sulfate has been our drug of choice, and it has really not changed. We still use magnesium sulfate, except that we just don't know how exactly does it affect its anticonvulsant effect. However, we believe that much of the effects should be in the central nervous system, and a number of theories or hypotheses that have been put forth to explain how this magnesium sulfate works. This includes, among others, raising the seizure threshold by its action at the N-methyl and D-aspartate receptor, stabilizing the membranes in the CNS by its action as a non-specific calcium channel blocker. And that's why we use calcium gluconate as an antidote, and decreasing acetylcholine transmission in the motor nerve terminals, among other hypotheses that have been put forth. Which patients should get magnesium sulfate? Now, there was a trial called the Makerere trial, and I think Prof. National may either attest or dispute. It could be the largest trial so far in the use of magnesium sulfate in pregnant women. And in that trial, it was found that you needed to give magnesium sulfate to 91 women overall to prevent occurrence of one seizure. However, when that analysis was broken down, the authors found that 63 women with preeclampsia with severe features. I'm using severe preeclampsia here because that trial was done before our new classification. You needed to give to 63 mothers with severe preeclampsia in order to prevent one seizure. Among those who have what we used to be mild preeclampsia, but currently preeclampsia without severe features, you needed 109 women to prevent one seizure. So what is the implication of this? That if you are well resourced, it's reasonable for you to say, let us only give magnesium sulfate to mothers with preeclampsia with severe features. However, in our guidelines, we reason that we need to give magnesium sulfate to all mothers, irrespective of the severity of the disease. I know many of you will be nodding your head. Why? Since we are less resourced. These resources we are talking about is not ability to purchase magnesium sulfate. It is your ability to segregate mothers into preeclampsia with severe features and preeclampsia without severe features. Now, for you to say this mother has preeclampsia without severe features or with severe features, you need a thorough history, a detailed history taking, which all of us are competent and trained to do so. You need a thorough physical examination to look for the signs that fall under severe features. And then you need laboratory investigations that Dr. Nakalabi talked about, and also imaging. Now, the first two, we are good at it, the history and the physical exam. But when it comes to laboratory and imaging, our ability is not that superb. So because we know that preeclampsia does not necessarily progress from what used to be mild to severe and then eclampsia, someone can actually progress from what the mild form of the disease to eclampsia without any warning sign. So we thought it is prudent for us who do not have the capacity to thoroughly isolate patients into severe features and without severe features. We better give magnesium sulfate to everyone. So the dosing has really not changed much. We still give the same loading dose, and I won't talk much about them. However, I will mention that if a patient convulses again, what do? We give them half the loading dose, the IV dose, which is 2 grams of 20%, and we continue with the maintenance dose. Now, for you to give maintenance dose, you must prove that there is no magnesium toxicity. And that means you need to do a clinical assessment every 1 to 2 hours to look out for signs of magnesium toxicity. And this includes checking for patellar reflex, respiratory rate, and urine output. And you only give the maintenance dose if you see patellar reflex is present, your respiration is more than 12, and your urine output is at least 100 mils in 4 hours. But I don't know the last time, I don't know when I last saw patellar hammer in labor. Now, magnesium sulfate toxicity correlates with the levels in the serum. So the first thing that appears with magnesium sulfate toxicity is loss of deep tendon reflexes. Most of us go respiratory count. That's not the first thing. So all we need to do is we need to at least do, we check the reflexes. If present, then that can work for us. So you do not want to go to the last two. That is loss of cardiac conduction, or alteration or cardiac arrest. Because when those two happen, we are not well equipped to rescue that mother. So we better get things as early as possible. So when the toxicity is present, our antidote is calcium gluconate. However, calcium chloride is an acceptable alternative. But the problem with it is that it causes a lot of irritation And should there be extravasation when you are administering the drug, you are likely to cause tissue necrosis. Now, one thing I want to emphasize is that we like to prescribe magnesium sulfate without lignocaine. I think the residents here, especially second years, they will know that when I try to emphasize the importance of giving lignocaine, I tell them if you want to know how painful the drug is, then give it to yourself. You will never prescribe it without what? Lignocaine. Now, there are circumstances where you also need to adjust the dose of magnesium sulfate, and that's mainly renal insufficiency because the drug is excreted through the kidneys. So patients who have renal insufficiency should get their standard loading dose. However, the maintenance dose needs to be adjusted depending on the serum creatinine levels. So if you have your serum creatinine level more than 1.1, but less than 2.5 milligrams per deciliter, you can give a maintenance dose of 1 gram per hour. This 1 gram per hour is for centers that use intravenous infusion as their maintenance dose. For us who are giving IM, we think we need to just half the dose of the drug. So instead of giving 5 grams or 50%, you give 2.5 grams of of magnesium sulfate. That's 50%. Now, if the serum creatinine level is more than 2.5 and above, or there is evidence of magnesium sulfate toxicity, you do not give maintenance dose. Now, there are two things here. If you have renal insufficiency without magnesium sulfate toxicity, you give an adjusted maintenance dose. If you have renal insufficiency without magnesium sulfate toxicity, you do not give. Yes.
Say that again.
I say it again. You have magnesium sulfate toxicity with a normal renal function, you don't give. But you have renal insufficiency without magnesium sulfate toxicity, you give a half the dose of the maintenance dose. What is the science? The science is that as you give the drug, less is going to be cleared. More is remaining in the patient's body. You accumulate more magnesium in the serum, and then subsequently, from insufficiency, then it leads to toxicity. But when you already have toxicity, even if the renal function is still good, you cannot give because there's already a problem. Now, the second goal is control of hypertension. Hypertension is classified into severe and non-severe. And severe hypertension is a systolic of 160 and above, or a diastolic of a diastolic of 110 and above. Now, in the past, we used to think that we only give antihypertensives to mothers who have blood pressure in severe range. This is no longer true. There's a lot of evidence that has shown that tight blood control has a much better maternal and fetal outcomes. And so many organizations are recommending that the threshold for giving antihypertensives should just be a diagnosis of hypertension. So once someone has a blood pressure of 140 over 90 millimeters of mercury, that qualifies that patient to receive antihypertensive therapy. Now, what we need to know is that treating hypertension does not prevent eclampsia, or it does not prevent progression of the disease. The intention of giving antihypertensives is to prevent end organ damage, particularly stroke or cerebrovascular accident. So how do we treat severe hypertension, which is a BP of 160 over a diastolic of 110? As earlier on said, this should be confirmed within minutes. So within 15 minutes, we do not wait for 4 hours to repeat that blood pressure. So the purpose is to initiate timely treatment, which should be within 30 to 60 minutes. And the blood pressure should be lowered gradually. This is not like treating PPH where you pump people fluids very fast. Yes, there's a risk of hypertension, but you need to lower the blood pressure gradually in order to avoid ischemic stroke. The choice of drugs are IV labetalol or IV hydralazine or immediate release oral nifedipine, which I think is not yet available in our public facilities. You use these drugs singly, one at a time, not in combination. And there is absolutely no reason for anyone at this time to use sublingual nifedipine. Even the physicians don't like it anymore. So our target blood pressure is 135 over 85 millimeters of mercury. Now, if you don't come to that figure, don't beat your head because blood pressure is not a fixed figure. So when you achieve a blood pressure, a systolic range of 130 to 139 over 80 to 89, you are good to go. You don't have to struggle to come to 135. But if you can have that, then you are really good at managing that pressure. Then treatment of non-severe hypertension. Non-severe hypertension is when BP is less than 160 over less than 109 millimeters of mercury. And the goals are still the same, to prevent end organ damage, and the dosages should be titrated accordingly with the response. So our drugs of choice are labetalol, nifedipine, methyl dopa, or a combination of all of the three. And the target blood pressure as for severe hypertension is the same. Our third goal is delivery of the placenta, actually, not the baby. I think Prof. will say that it is the placenta which is necessary, but not the fetus. Of course, it will be logical for someone to say that I'm going to deliver the placenta and leave the baby behind. So, delivery becomes our ultimate treatment of preeclampsia. Now, the most difficult season in managing these patients is the time of delivery. When do you say, I need to deliver this patient? Because we know delivery minimizes the risk of maternal and fetal complications, which are very many. Dr. Sechu already talked about. The fetal complications when they are not yet delivered include fetal growth restriction and IFD, which may occur because of abraxoplasenia, which is one of the complications of preeclampsia, or placental insufficiency. Now, other than fetal growth restriction, the rest of the complications can strike suddenly without warning anyone. So meaning that as you think of delayed pregnancy or delayed delivery, just know any of this can happen to the mother. So the decision to deliver the mother is based on these three. One is the gestational age, the maternal condition and the fetal condition, and the severity of the disease. Generally, once a mother has reached 37 weeks, we have to deliver that mother. There is no additional benefit that you can accrue from prolonging a pregnancy that has already reached 37 weeks. And our target is to initiate delivery within 24 hours, irrespective of whether the mother has severe features or doesn't have. Then for other mothers, you need to determine if there is an indication for immediate delivery. And we shall look at what are these indications that require immediate delivery, irrespective of the gestational age. So if there is no indication for immediate delivery, you can choose to offer expectant management, provided the mother is not compromised and the fetus is also not compromised. So what are the indications for immediate delivery, which we can also say contraindications for prolonging the pregnancy? So we have abnormal neurological features. These include eclampsia, stroke, and others. Repeated episodes of severe hypertension, despite use of 3 different antihypertensives. you are not achieving blood pressures below 160 or diastolic less than 110, even after giving 3 drugs. Pulmonary edema, worsening thrombocytopenia, that's less than 100,000, or they need to transfuse that mother. Then you have worsening other labs. Dr. Miriam talked about liver functions and renal functions. When there's a hemodynamic instability, or there's non-reassuring fetal status. And how do we define non-reassuring? You have abnormal non-stress test. You have oligohydramnios or low biophysical profile, or there's evidence of IUTR, or you have absent or reduced end diastolic flow velocity when you perform your umbilical artery Doppler velocimetry. Or there's no expectation for survival at diagnosis. For example, you're making a diagnosis at 20 weeks. These are mothers who should be counseled for discontinuation of the pregnancy. When there's abruption or people, or a mother has myocardial infarction, HELLP syndrome, acute kidney injury, all those will find a mother for immediate delivery of the baby. The last one is controversial, maternal request for delivery. Now, even if you, in the opinion of the clinician, however much experience or well-trained you are, a mother says, I want this baby delivered, go ahead and deliver. Because should anything go wrong with her after you refusing to say, let us prolong the pregnancy, you will see how to get out of the backlog. So if you choose to do expectant management, what we need to know is that most patients, after looking at the indications of severe, indications for immediate delivery, you have to realize that most patients with preeclampsia with severe features are delivered promptly. Now, one word which we have not said throughout the ground round is the word progressive. Preeclampsia is a progressive disease. And we know there is no medical treatment to prevent progression, except the fact that we have magnesium sulfate that we can use to prevent seizures. So because of that, delivery is always in the best interest of the mother. However, preterm delivery may not be in the best interest of the newborn. Because this delivery we are talking about also comes with the cost to the baby. You do preterm delivery, you know the consequences that Dr. Sextubo illustrated. So to delay delivery might give you room to allow some fetal maturity and subsequently reduce neonatal morbidity and mortality under certain conditions. Of course, as I said, this does not come without any risk. The risk of expectant management is that the mother can easily have end organ damage, which may even be severe, and the fetus may still have IUTR ongoing and also fetal demise. So, because of these challenges, the decision to do expectant management should be a shared decision making between the care providers and the client and their family. And while making this shared decision, it should be made well aware to the mother that there is absolutely no direct benefit to the mother by continuing the pregnancy. Instead, the mother is taking a very big risk to her own health because of the complications that are likely to arise when you delay delivery. So such decisions to do expectant management should be clearly documented, and they have to be revisited over time at regular intervals, just like what the Women's Hospital did with this patient. Every time they are talking about delivery, but declines, you document. Okay. So just to emphasize that there must be no contraindication for expectant management for you to undergo it. So what do we do when we choose to do expectant management? So we divide this when we have preeclampsia with severe features. So for these mothers who have preeclampsia with severe features, the expectant management should be in hospital. There's no patient care for these mothers. So you have to do daily maternal and fetal assessment for indication for immediate delivery. And what we mean here is what MD said: thorough history, thorough physical examination, to see if there's any symptom or sign that they have developed that necessitates termination or discontinuation of the pregnancy. They need to do daily labs, the labs that Dr. Nakal talked about. And in some facilities, the recommendation is actually that you should do labs every 6 to 12 hours. When you look at our resources, I don't want to talk about that. No one can afford that. It's not possible. So we reason that doing labs every day for a mother with preeclampsia of severe features is a bit achievable. So we need to control blood pressure, as we talked about. Obviously, magnesium sulfate needs to be given. And for those pregnancies that are less than 34 weeks, you need to administer corticosteroid for fetal lung maturity. Daily CT cardiotocograph, if it is available. Of course, they should be available there. We are also advanced. We are not always behind. So the other thing is strict fluid input and output management. I was a bit shocked when I saw the person from the women was given 2.4 liters of IV fluid. I wonder what was the indication. Yet these are mothers who much as they appear to be having a lot of fluid in their body, the fluid is not it's not intravascular. And you can have a big risk of pulmonary edema if you do not do controlled fluid intake. Then at least twice weekly, but ideally they will say once every day you should do ultrasound scan for all those, but we also know that that may not be feasible. So should there be an indication for immediate delivery arising? So this expectant management needs to be terminated immediately and you deliver the patient. If a mother has preeclampsia without severe features, what do we do for them? We do all the things I have mentioned, except that we do it as outpatient and on weekly basis. Now, the last point here is strict bed rest is not recommended. As Prof said, Dr. said they were managing patients in darkness, so I want to talk about that. But also tell the patients not to leave their bed is not recommended because there's the other issue that can also kill DVT. So just a quick summary of what can you do when you get a mother with hypertension. Taking a thorough history to look for severe features, thoroughly examine the patient to determine any severe signs, do the labs, look for what Dr. Sechko said, any organ damage or complications, do ultrasound scan for fetal growth and fetal well-being, determine if the patient has preeclampsia. Not every hypertensive patient has preeclampsia anyway. Now, if the patient has preeclampsia, determine if it is severe or without severe. Sometimes I think in Kawembe, we might be wrong in assigning patients. Because sometimes the only thing the patient has is history and physical exam, and then we say preeclampsia without severe features. No one knows what the renal function is, no one knows what the liver functions are. So if the patient has preeclampsia, then determine if they are severe or without severe features, then give magnesium sulfate, treat hypertension appropriately, determine if the mother is at term or not at term. Of course, at term we're talking about 37 weeks and above. If the patient is at term, deliver that patient immediately, initiate delivery within 24 hours. If the patient is not at term, determine if there is indication for immediate delivery. If there is no indication for immediate delivery, then offer expectant management. Once you offer expectant management, you just do this up at 7 weeks and you deliver. So a few things just to highlight about intrapartum care. One is route of delivery is based on obstetric indication. Yes, we know that we want to expedite delivery, but that does not mean that all mothers need to be operated. Preeclampsia is not an absolute indication for cesarean section. I've already talked about fluid management. It should be limited to 80 ml per hour, and you are better off giving oral fluids than intravenous fluids. Dr. Chin will talk about labor analgesics, I think. Postpartum care, I will say a few things. Dr. Antio will do the rest. Close monitoring for at least 3 days. Some patients may require more monitoring in hospital. You need to have continued follow-up until signs and symptoms of preeclampsia have resolved. You repeat labs like the ones they did in lab before you discharge the patient. The labs will at least show for you that either they are normal, or if they are not normal, they are at least going towards normal. I think your patient was discharged when they were not normal, but they were going down. So that was a good one. So you complete magnesium sulfate. If it has not, if you have not finished, you adjust antihypertensive therapy accordingly. Some patients may need to be discharged on antihypertensives and then discontinued after the BP has normalized. Now, when to stop antihypertensives is very difficult. Prof, that might get come an index study that says you stop at this day, we stop at this point, I did. Now, this is my personal opinion. Okay. Yeah, in medical school, we have to speak evidence. So my opinion is not really an evidence, but you can take or not take. I believe that it is better to taper antihypertensives rather than just stop abruptly, even if the blood pressure is normalized. Because you cannot know whether this blood pressure is now normal because the disease has resolved, or it's actually your drugs working. Now, when you stop the blood pressure, the drugs, before the blood pressure has, the disease has actually resolved, you are likely to have a rebound hypertension. So that is my opinion to say that it is better we taper antihypertensives rather than just stopping. So we need to review these matters at 1 week, 6 weeks, and 12 weeks postpartum, because preeclampsia may not resolve by 12 weeks. And the other follow-up things, Dr. Trio will do this. Those are some of the references I use, and I want to thank you for
more than that. So usually, especially when you are here and you have an opinion, you need to see how you can do research on that. That's best. So members, the big thing. This is one of, we always say again, these basics are so important that when you are examining the abdomen, you must compare Fahrenheit with good subamenoria. Always. You have to reach Fahrenheit and just continue. The difference of 2 weeks is significant. Now, here, not comparing Fahrenheit with good subamenoria is a crime, because it means that you don't understand the pathophysiology and how it works, because here there is always a complication, the possible complication of IUGR. So you need to make sure you emphasize it. So even if the mother doesn't know, say, I would have right to compare, but the mother doesn't remember the dates. The purposes of clinical examination and laboratory investigation members always, the other day, one question on it, which is you confirm the diagnosis, but at the same time, you check for possible complications. You can always have that as a target for both clinical exam and investigations. Now, a question for you here, members. You have a patient on the ward. You are managing her for preeclampsia. When you come, you find that the abdomen is not moving with your respiration. What is the likely cause? That is for you to think through. Now, the other one was about bed rest. When somebody mentioned the bed rest on our side, somebody was saying, so what should one do? Bed rest, they say, can increase complications, so it is no longer recommended, as we were talking previously. But they say physical activity could be reduced, and that is different from bed rest, because they said it may have an impact on the fetal well-being. So that's something to consider. So members, for that question, one of the possibilities can be abruptio placenta would have developed, and as you know, is one of the causes, and hypertension can be one of the predisposing factors. Sister, we have the next one, nursing care in preeclamptic patient, that is Sister Rehma. Rehma has actively participated in managing patients for a long time. How to manage. Now, of course, we are also doing some time check. Members want to be sure that we can be speaking within the short time that is allocated, so that we can be on schedule. So thank you very much, sister. If you want to say one or two words about your service, feel free. You're welcome.
Ladies and gentlemen, those are my names. National Referral Hospital. Most of it has been said, but all that has been said mostly is done by the nurse or the midwife. So we continue. Everything that has been said really is contributed by the nurse or the midwife. When she's absent, nothing is possible. Okay, the definition has already been said, but we very well know that the disease can progress to eclampsia. It can present in antenatal, labor, and postnatal. And therefore, the nursing care is really paramount. Documentation of the care given is very important because what is not documented is not done. Actually, why nursing care? Nursing care is really important because the condition requires monitoring. And who does the monitoring? It is the nurse or the midwife. It requires diagnostic interventions. And who starts taking off blood and other interventions? Actually, it also requires treatment for a good clinical outcome. And actually, it is the nurse who does it. In situations of severity, it requires intensive care. And it is the nurse who is that patient for most of the time. It needs engagement of the relatives, the staff for good management. Once the relatives are not engaged, then we are doing a lot of nothing because relatives have to know. Actually, in our management, in our nursing care, we need to be readily prepared. Whether we like it or not, we need to take care of availability of all what is required in the medicine as mentioned above. The sundries must all be available most of the time for us to ease the monitoring and management. We need to have the equipment readily available because once you need to do your monitoring and you have equipments which are non-functional, then you are doing a lot of nothing. You cannot progress in your work, in your care. And we need to have instruments that are readily available, sterilized and well decontaminated, ready to handle an emergency. We do provide care right from antenatal. For those who are known or not known, but basically, health education is very important to the mothers and the family members, just to understand for any danger sign that might arise to a mother. And also to increase social support to anyone who is providing care to that mother. And if a midwife doesn't do it or a nurse, nobody can intervene. They need to know. So we need to encourage our mothers to follow up the instructions on when to access health care and to follow up regularly. If they are not told, in case if they are not in the severe form, they can relapse, and you find that the disease, the condition might progress. We need to ensure that mothers are having their medicine as prescribed. And it is very necessary to give information about any medicine that is going to be administered. Most of the time, we think of monitoring, but what are we to monitor? We need to know the blood pressure values. We need to identify the normal from the abnormal. Because if you cannot know the abnormal, the BPs are present, and you cannot know what to do, then it's a problem. We need to know all those values as in comparison from the normal. It's us to collect the relevant blood samples most of the time. If we don't care about taking off blood samples and urine samples and getting to know how to interpret, then it is dangerous. We need to ensure that mothers who are admitted are having IV lines in situ, and a catheter should be inserted under aseptic techniques. We monitor, as we are giving treatment, any drug reactions like magnesium toxicity, and intervene with any treatment with calcium gluconate. And we need to monitor the fluid intake and urine output, at least urine up to 30 mL per hour, to rule out any kidney injury. We need to monitor the urine protein at least once in 24 hours on a daily basis for those ones who are admitted. So we need to monitor still the fetal heart. And in case if a mother is in labor, we refer to the pathograph monitoring because it is a standard tool that helps us to monitor our baby. We need to ensure that our ultrasound scan is done and we are able to interpret for any complication that can arise. We need to have a continuous communication to our mother and the relatives for any disease progression. And they need to know when they need to be concerned about anything like termination of pregnancy in case of any disease progression. For the dieting, they need to take a normal dieting because sometimes they tend to think of restricting themselves from taking salty dieting, but it is not it is not accepted. They need to take a normal diet. So we need to give them information about all that. So we need to observe when admitted for any herbal medicine that could be kept or taken around. And everything which is done on the patient has to be documented. Because what is documented, what is not documented is not done. And during labor, in case of any convulsion, in case of any progression of eclampsia, we need to protect our mother from injury. Usually what we do for any mother suspected with severe features, we need to admit her on a bed which has protectives. And we ensure that those rails to protect our mothers. We need to put our mother in a left lateral position in case if there is any convulsion that has done what? That has come. But not only that, still we need to discourage them to sleep in a spine position to prevent spine hypotension to our baby and the mother. We need to take care of the mother's hygiene with involvement of the attendants and the staff. So mother's hygiene is really key. She's in labor. sometimes she cannot afford cleaning herself, but it's you, the nurse or a midwife, to take care of her hygiene. When you're working hand in hand with attendants, there you can work on it, clean mother, and prevent infections. We need to monitor vitals still in labor using a pathograph and give treatment as per the prescription and as per the protocol. In case of any contraindication to vaginal delivery, still it is a nurse or a midwife to prepare this mother for cesarean section delivery. Under puerperium, still we continue as nurses to watch out for danger signs and symptoms as mentioned above, and we need to continue monitoring all vitals as mentioned. We need to continue with the treatment, especially the anticonvulsants and antihypertensives, and give the antibiotic as prescribed. Mother's diet still has to be monitored, preferably should take plenty of foods. No restrictions. Postnatal still needs follow-up, especially within the first 24 to 48 hours when on admission. So it is very important for a nurse or a midwife on duty to continue with that. We need to, it's not encouraged. We are not encouraging them to rest. Sorry, we can jump that. But all in all, as nurses and midwives, we have a unique tool that frames critical thinking to healthcare professionals. And currently, this summarizes all what we do in our nursing care. In assessment, it has 5 steps, as mentioned above. We do assess, we do diagnose, because we have our nursing diagnoses, which are different from the medical diagnosis. We plan, we implement, and evaluate. Thank you.
Thank you very much. Thank you very much, Mr. Rehman. You can see somebody who is very practical. And it shows. Now you get to the next one. So members, as you can see, as you talk to the mother, you bring in the next of kin, like the husband or partner, because of the post-partum complication, as sister has emphasized. Andrew Chip was, yeah, he's around, yes. Very good. Andrew Chip is been working very closely with the Department of Obstetrics and Gynecology, but he also has a lot of interest in obstetric, anesthesia, and other related subjects. He brings in the aspect of interdepartmental multidisciplinary team in the management of these patients. So, so you are very, very welcome.
Thank you. I'm going to talk about preeclampsia and anesthesia. So this also needs another brown round. So my presentation won't be long because I'll try to be brief, and most of the things have actually been mentioned by my other senior colleagues who have been presenting. So, as already mentioned, preeclampsia, we all know it is a multi-system disorder. And preeclampsia itself, it poses a unique concern to the anesthesiologist, because not just like any other patient, but there are other several things that you need to think about, and sometimes are considered as disaster to anesthesiologists. And it also accounts for a lot of morbidity and mortality, because most of the patients that actually present with preeclampsia or eclampsia for anesthesia are usually in severe state. So which poses a lot of risk for these mothers. And if you don't do the right precautions, many times you end up with a lot of morbidity. Some of the things that actually I want to just pick up, and are not just only that, it comes along with things like placental abruption, which I'm sure all of you know. One of the things that I personally fear most is the cerebral hemorrhage, which happens a lot at induction of anesthesia. And I've seen very many patients coming from Kawempe, and the most common reason for admission to the ICU is cerebral hemorrhage. Pulmonary edema is one of them, which accounts for about 2% in most of the patients. It may not be that common, but if you also think about the pathophysiology of preeclampsia, it's something, if it happens, it's quite fatal. So also acute kidney injury is another thing. And looking at our state in the country, you don't want your patients to get acute kidney injury because, you know, the facilities that can actually help us dialyze these patients are quite few. And most of the times we actually detect it late because of our poor monitoring facilities. So it's better you prevent it. Other things include things like hepatic rupture and failure, then DIC, and then the patient can also progress to eclampsia. So I'll briefly just talk about the pre-anesthetic evaluation. Ideally, this should be coming quite early during labor process because we know all these mothers can potentially progress into emergency cases. So you need to evaluate these people quite early in their progress of labor. And the focus mainly should focus on the severity of the disease, which has already been mentioned. So mainly looking at the features of severe preeclampsia. And then most of the things that we value most are things like the airway. And we know if you look at all the changes that take place in preeclampsia, we have the edema, engorgement. Some of these patients have been convulsing, so they are bleeding. So you may not actually be able to intubate those patients. And some of these things that actually could highlight those things, you may actually find the patient with a stridor even before you give you anesthesia. Now that's the area where you do not want to anesthetize. And looking at the state of activities or state of our infrastructure, we don't have those additive gadgets or the anesthesia toys that we would like to use to be able to do secure the airway of these patients. And then the hemodynamic status of the patient, so blood pressure control and everything, looking at the coordination parameters. And also you need to bear in mind that as much as you review this, they can change within a few seconds. So you having to treat the mother in the morning does not necessarily mean she's okay after 4 hours. Everything changes, but at least it gives you an outline. So ideally, if you're in a good working system, if you have mothers with preeclampsia who have started actually going into labor, anesthesia provider should actually go into those places and review those mothers, at least that in case you're called in, you know what kind of patient you're going to receive. So there's a question of where should we look after these mothers? Is it in the ICU? Is it on the labor ward? So it's a question of the facility that you also in. So the decision to take care of these patients, whether labor or ICU, mainly depends on the institution and what are the protocols of that institution? Where do you want to keep these mothers? And then it should also be a collaboration between the anesthesia team, the obstetric team, the nursing team, maybe also the physicians. If you have MFM physicians, you should also involve them quite early enough so that you plan for these mothers. And then also, it's also based on the availability of resources in your unit or in your facility. And then what kind of expertise do you have in that unit that you may need to utilize for the care of these mothers? Because you could actually just decide to put them on the ward that has just special monitoring or nurses dedicated to preeclampsia and look out for those things. And then some other things why you could also sometimes prefer to keep these mothers on the level of this mother. The nurses on those wards are used to looking after pregnant mothers and they can help you monitor. But however, remember that sometimes these mothers also may require things like invasive monitoring and all that. So if you have such a mother, then it's better you keep them in an ICU because within the ICU, you have nurses that are specifically trained to interpret and use the invasive monitoring and everything. So what are the aims when you're trying to think about how to reduce maternal and fetal complications? So most of these things have already been emphasized and I'll re-emphasize them. So treatment of hypertension, you need to treat that hypertension. You need to control the convulsions, then the fluid therapy that has already been mentioned, and also management of oliguria. Decision when to deliver, when do you want to deliver this mother? It's something that should be collective, multidisciplinary, not just one person decision. Many times, the few times when I used to go to Kawente, you're in the labor theater, and before you know it, at the entrance of theater, they bring a mother who is still actually convulsing, which to me is painful. And most of the times, these are the mothers that actually you find they're anesthetized and they never wake up. If you're to think about the pathophysiology, we've actually done them a disservice. So fluids, I'll emphasize the fluids, it has already been mentioned. I'll talk about it more because it's also a killer in preeclampsia. So fluid restriction should be taken to prevent things like pulmonary edema and cerebral edema. And I've already mentioned the incidence before of that. So if you look at the pathophysiology, we have many times we have left ventricular diastolic dysfunction. We have reduced colloidal pressure with increased permeability of most of the capillaries. And remember, because of the hypertension, you have an increased afterload. So if you try to pour in fluid in something that has resistance at the end, which is afterload, with increased permeability, what is going to happen is that all this fluid is going to move out into the peripheries. So which also may cause you disaster. So it will cause you issues like you get edema in every place, including your intestines, your lungs, and everything gets complicated with that. The airway, which is also a disaster to some of us. So currently, the regimen that they actually talk about in terms of fluid management, they talk about giving at least 1 ml per kilogram per hour of fluids. But this means also the oral thing. So it means everything in totality that you're giving. So you give up about 80 ml per hour. But however, if your mother is bleeding or they have additional losses, you need to account that into your fluid therapy. You don't say that Dr. Chin told us to stop at 80 ml if you have a bleeding mother. So you need to put that into clinical picture and assess your mother and say, my mother is bleeding, she has lost this amount of blood, and I need to replace the fluid. So I'll talk a bit more about oliguria. You notice I've talked about a lot about fluids. Postnatally, you need to talk about fluid restriction as you're doing even before delivering the mother. So ideally, you should be monitoring the urine output 4 hourly, if you can, more especially in centers that are quite busy, because we may not be able to do it every hour. But at least you need to assess and find out how much urine has my mother produced in the last 4 hours. And remember, in preeclampsia, you have what we call the permissive oliguria, because they will have it. So don't just sit and then just flood them or give them Lasix without even think about the clinical picture of the patient. So it is acceptable. So, but if you notice that actually within the 4 hours or the other 4 hours, your mother has not produced enough urine, but you've also been balancing how much you've been putting in and how much has been going out. And your mother's maybe say positive 750. When I say positive, is you're trying to balance what you put in versus what has come out. If you're positive by that, then you could maybe try to give them a shot of Lasix. But however, if you're below 750, you may need to give them a bolus of about 250, but again, precautiously. And then if you try that and it fails, and you also have a raising serotonin, creatinine level, that's when you may need to think about involving the renal physician quite early. Do not wait for the end stages, but all this to happen, you need to be able to monitor your patients and document, because you will not actually notice that actually my patient is going into AKI if you're not monitoring them. So anesthesia for these mothers. So wherever you go in the world, Niraxone is the preferred technique for anesthesia for these mothers for several reasons. So there are two things, because of interest, I'll try to bring it down. So there are two things that you actually fear in these mothers. One, is failure to manage the airway because of the changes. 2 is when you're trying to intubate them all at induction, there's that stress response to the catecholamine that goes surging. So what usually happens is that your blood pressures actually shoot up. And when they shoot up, you get bleeding. And most times, if you're very observant, or you're in a setting that has all the good monitors, you actually see the trial on the screens. You see your blood pressures, your heart rate going down and everything, and actually to tell you that actually you bled. And it's actually very clear. You see, most times people don't need to sit, but they actually notice their mothers are not waking up and are starting to crash on them. But if you do the Rapso, it helps you avoid all these things. So some of the indications of general anesthesia include things like pulmonary edema that requires invasive ventilation, that you may need to intubate the group that to maintain the oxygenation, severe coagulopathy, severe thrombocytopenia, and then also the mother declining to Rapso anesthesia, and then DIC. And then on top of the other considerations of general anesthesia in the non-severe preeclamptics, you also need to put in other things like managing the airway, ramping them up to increase on your FRC because of the position, reducing the passive regurgitation, and then also the venous pooling, reducing on the chances of the CVS when you're intubating them, and also trying to blunt the airway reflexes to laryngoscopy. There are several things that have been used, things like magnesium sulfate can be used, but however, you need to think about it with precaution because some of these mothers have already been on infusions. So if you have things that point fit, we try as much as possible to deliver our mothers as soon as possible. But stabilization of the mother should not be superseded by the rush to deliver your mothers, because many times you need to weigh risk, and it's not written in stone, but you need to clinically make a judgment and say, will my mother come out of this? Am I doing the safest way? What do I need to do? Because I usually tell most people that the rule is if the mother is safe, the baby is safe. And if the mother is not safe, the baby will never be safe. So this is the time when you need to control your blood pressures, you need to take off samples in anticipation for maybe an emergency cesarean section or whatever may happen. And then delayed delivery sometimes may help the mother recover. Maybe you may be able to give them a Rapso block. Maybe you may also be able to get a consent from them to be able to do regional anesthesia in them. And then also operation of this mother, in case you need to do general anesthesia, we actually talk to them about pre-oxygenation. Are you together? So the postpartum care has been emphasized. These mothers continue to be at risk for things like convulsions, pulmonary edema, stroke, VTE, and remember we've talked about things like venous thromboembolism prophylaxis. Remember that these mothers also have severe thrombocytopenia sometimes. So when you think about it, you need to weigh at what level or at what stage do I give my Clexane all anticoagulants. Ideally, if your platelet is above 8 and there are no signs of bleeding, you can actually start it because remember that risk of VTE. Maybe something just to mention, I'll take a bit back. There is no absolute platelet count at which you can give Rapso. It's still controversial. So you need to do your clinical judgment. Though most times 50 is the value, but if you're to do something like an epidural, we take about 75 as long as there's no other coagulopathy within this patient. So you need to think about the case studies that have shown that patients have been with platelets as low as 20 without much bleeding and all that. And the chances that you'll actually get a spinal hematoma, the question that we will ask ourselves when we are discussing that, if I'm afraid of the small needle in the back, why am I letting my surgeon make that big incision on the abdomen? But there's no clinical evidence to that. Don't take it as gospel truth. But it's an argument that we usually have, that if I can risk them cutting my mother, why am I afraid of the small needle? But there are things that have come into play that you can actually use I'll skip labor now, yes, yeah? So things like use of ultrasound. It has actually tried to make it more accurate and more safe, giving spinal anesthesia in this matter. So we do ultrasound guided spinal or neuraxial blocks. And then these other things also for pain management, can use rectal shift block, transversus abdominis block. And then also the ultrasound has come into play in trying to guide fluid therapy in these matters. So there is the bedside ultrasound, which is becoming the new stethoscope. So everyone should learn how to use a bedside ultrasound to look at the lungs, look at the heart and everything. So even the echo, it helps you try to find out the cardiac output, looking at your ejection fraction, looking at your right heart function, in case you're suspecting things like an embolic phenomena. So it will show you the strain and all that, and then to give you an idea. And then if you're having places where you're having uremia, also the echo may give you an idea of what the most likely cause is. Is it your heart failure? Because remember, these mothers also get heart or cardiac dysfunction. Thank you very much.
Thank you very much, Dr. Chief, for those very important points in regard to patients' survival. Dr. Saranakuruba is seems like one of around. So please, members of the line, we are with you and continue to receive greetings from us. So we now have Dr. Saranakuruba talk about the Eclampsia kit and performer. I'm sure members are very eager to listen to what that is. Saranakuruba has been very actively preparing. He's been one of the key organizers.
Thank you very much, Professor, and thank you all for listening very keenly. The next presentation should have been done by my colleague, my sister, Dr. Scovia Nalugo Balinda, but she's stuck in traffic in Tebe. She needed to pick someone. Before I start that, maybe I'll tell you a story. I went for a visit, what we call mentorship in Mukono. And while we were having a CME with the midwives, our patients were brought in convulsing. So, post the call for help, we were there, I and two senior midwives, and then we go and start. So I'm like, where is magnesium sulfate? Then there's no magnesium sulfate. Then they send the husband takes the order to go and buy magnesium sulfate. He got a mild accident, but he managed to come back sweating and a little bit with some bit of abrasion in the face. And then he brings magnesium sulfate. So I'm like, where are the syringes? Then someone runs for them. Do you know, everything was just dramatic. But thank God we managed to assemble everything and we were able to save the patient. But it shouldn't be like that. All right, so we need to have things in place. All right, the next slide. So in a kit, all these things should be there. At least to manage one patient for 24 hours. 10 5-gram ampules of mag sulfate, at least 4 tablets of nifedipine, at least 6 tablets of methyl dopa, at least 3 vials of hydralazine, labetalol, at least 10 vials. Of course, putting in mind the dosage which were told by Dr. Droma. And then also calcium gluconate should be there, lignocaine, plus or minus dexamethasone in case the patient needs it. Then we need supply syringes, a whole range of 20 ml, 2, 10 ml, 6, 5 ml, water for injection, urethral catheters, in case one has got an issue, then you can insert another one. Urinary bag, alcohol swabs. Apparently, the National Medical Store supplies alcohol swabs, fluids, even set, gloves, different types of gloves, and then of course plaster. And we are developing some of these as a team of experts, both midwives and obstetricians, so that this can be available. And then it should be posted so that if someone wants to help you, they're able to buy that. And all these are in one box or tray, and you're able to pick them. There are advantages. Everything is one place. You don't have to cross the road, dodge borders and all that. No need to rush for items fast and stress-free. And obviously you reduce morbidity because you're able to work earlier. It's also an option, especially for all units, but more especially for lower units. That was a health center for somewhere in Koja, and then in an ambulance. So that's the first part of the presentation. Then the next part is the performer. There are issues with documentation. Many of us do a lot of things, but we find it very hard to document. And there's a performer, again, the team is developing. You'll see the names of the people as we go along. And the performer has a part for identification. The next slide. That was the presentation for the performer. All right, it has a part for identification of the patient, and then the team that is on duty, which is very key. And well, this is for 8-hour shifts. We will discuss this more in a clinical setting, but for now, I want you to be exposed to this. So this is something that can help. Makerere University has a checklist, but we were developing something that may be similar, but with more information. And then the actions to take. The next slide. So I hope you can see. And then, so it has actions to take. You need to call for help. Was that done at what time? And a medical student can be recording, a midwife can be recording, a young midwife can be recording while the senior one is managing. Initial blood pressure taken, and we are hoping this will be incorporated in the HMIS system. And then urine protein done, urinary catheter inserted, complete blood count, renal function tests done, and if they are done, then you record them. Then the IV access, fetal heart rate, ultrasound. Remember, the ultrasound needs to be done. Again, more actions on the next slide. The drugs given, as Dr. Roma and my other colleagues talked about, hydralazine, labetalol, nifedipine, methyl-dopa, the mag sulfate, and then the initial loading, and then the maintenance, and then whether the delivery plan was made. You always have to have a delivery plan. Even though it's going to be tomorrow, you need to write it in a file. Of course, if it's today, obviously it should be there. So that should be on file. The fluids, they are not saying no fluids, but they should be documented if given and restricted. And then obviously there's need to communicate to the patients, and all that communication, if done, should be recorded when that was done. And if it's delivery transfer to ICU or HDU, also you need to report that that was done. And about the team being debriefed after the management of the patient, then you sit and see how you're faring. All those need to be documented. Then postoperatively, we also need to continue monitoring the patient. The next. Yes, so again, these are reflecting the different actions you're supposed to do postnatally. Magnesium sulfate dose given for maintenance. Remember, if someone has severe preeclampsia or has had a fit, eclampsia, then you're giving magnesium sulfate 6 doses after the last fit or after delivery, whichever occurred last. So that needs to be recorded. Maternal vital signs recorded the first 4 hours, rather the first 2 hours quarterly, and then obviously you can reduce depending on how the patient is faring. And all that, the recording is there. And urine dipstick daily, so you record what was it on day 1, day 2, then the results of the lab, 48-hourly, and then the discharge and follow-up plan discussed. You can say yes, you may write more details, but at least documented that it was done, and then review 1 week, 2 weeks. Sometimes patients are discharged after preeclampsia, and it's not clear when they are coming back and when you're going to see them. And it would also be good to have discussed the investigation that they are going to do when they are coming back. So, ladies and gentlemen, my presentation wasn't very long, hopefully.
Thank you very much. It was very, very informative. And maybe we need to see what of these things we are discussing today can we implement? Can we review what we do on the wards? Because all these aspects can help patients and make patients survive. So if you say checklist, what does it really take? Paper, but then what about maybe the utilization? Yeah, and I had people saying those things seem to be made right, but it looks like as medicine advances, we have to eventually keep doing a lot of writing, observation, drugs given, when, how, all those. So members, let's continue with the program. Today we are very rich. We have like the country, very rich. We have got somebody here, Dr. Agule Gabanji, is a transfusion medicine physician. So, tell us about yes.
Good afternoon. It's already evening. It's really my pleasure to be here. I'm not a gynecologist. My background is in pediatrics, but like professors said, I am a physician of transfusion. And a lot has been said. I will just speak a few things. So when you want to consider transfusion, the available products in this country are a little bit limited. One point to make clear here is that preeclampsia, eclampsia, and the other entities is actually a high accord level state. If you want to take one point, that is a check home. However, it tends to be a little bit compensated. A few physiological mechanisms come in to balance the body, like we normally say it, and I will show you how. However, about 30% of patients with the severe disease, such as HOP syndrome, may actually present with coagulopathy complications. So do not assume that most of your patients are compensated and none will get complications. My colleagues have talked about the hallmark of the disease in terms of etiology. What goes wrong is the damage to the endothelium. And we know that triggers a coagulation cascade. What you may not know is that once you trigger the coagulation cascade, a complement also is switched on. So the coagulation and the complement systems are great batteries. You don't turn on one and the other, remains idle. And so we see a lot of this, a lot of fibrin deposition, microvasculature, platelet activation, and all that, including the deposition of this complement component. So what activates platelets is the damage to the endothelium. So when things in the blood vessel that should not be seen become visible, the platelets get activated. That switches off the activation, the coagulation cascade. And once the platelets are activated, their great partners, von Wimbrand, comes and picks them up. And the two make a good couple and they go into a marriage. And those platelets that have been picked by von Wimbrand, they will not become available for coagulation. So that explains the thrombocytopenia. So it's a compensated coagulopathy state because some things remain normal, other things go abnormal. I'll just talk about the normal things. So things like protein S and protein C, we know these are very important naturally occurring anticoagulants, and these remain normal. And these are some of the things that help us balance the body. So we talk about a compensated coagulopathy state. But some other things go wrong, including the hemolysis. Just to emphasize, what is the mechanism of hemolysis in HELP syndrome? So the endothelium has been damaged. I equate it to a path which has rocks. If you walk over a path with rocks, with bare feet, what is going to happen? You will knock your feet. And that's what happens to the blood, the red blood cells. So when the red blood cells go through these damaged small vessels, the microvasculature, they will knock their feet and they break. And that's what causes hemolysis in this disease. So we say it is, and it's a non-immune, and it's occurring within those small vessels. I've talked about what causes the low platelet count. Because the partner picks the platelets and they go into a marriage. So we've talked about investigation, tests, but interpret them. So from a coagulation perspective, the four are the most important tests: a platelet count, fibrinogen, an INR, and the D-dimers. When you do these tests, please interpret them. Make use of this DIC score. It's a very important, you can Google DIC score. So you score each, and a score of more than some literature talk about 7, others talk about 8. But anything above 7 may actually be diagnostic of overt DIC. Then you know you are really in trouble. You have to go Dr. Kinto. So I will talk about what you can transfuse with. We can use blood. Now I've talked about hemolysis in this disease that it's really not very prominent, and really does it directly cause severe anemia. So in the end, the patients that may require blood transfusion are those that get complications, such as PPH and abruption. So it may not be much different from the other obstetrics and gynecological patients. So what I'm talking about is drawing the boundary between PET and non-PET. So there's not much difference, and we did dive into this. We had a very good time with the presidents during our camp. So when you transfuse, we transfuse if somebody is either anemic or is bleeding. But that's one indication. The other is the severe anemia or bleeding must be severe enough to cause inadequate oxygen carrying capacity. So we look at two things, the clinical and the laboratory. So this is the indication for transfusion. So thresholds such as 7 HB, or some people even be more restrictive and says 6. So, but does the patient have any signs of inadequate oxygen carrying capacity? That's the patient who may need to transfuse. Otherwise, just treat the underlying causes if they are not with those signs. Thrombocytopenia, we've talked about the mechanism. Now, it is not rare in our patient population, and the mechanism, I've talked about it. It is a thrombotic microangiopathy, TMS. It's a big group of hematological disorders, the TMS. So now, thrombocytopenia in preeclampsia is actually the second leading cause of thrombocytopenia. Is that clear? Thrombocytopenia from preeclamptic disease, blah, blah, is the second leading cause. The first one being benign, which we call the gestation thrombocytopenia. It's very common, but it rarely gives you counts that go below 100,000. So the gestation is very benign. Now, in those patients that get thrombocytopenia, we say it's not very rare. Only 5% may actually go with counts as low as 50. So it is not rare, but very few of the patients actually get very severe thrombocytopenia. And rarely we get counts below 20. However, we know that the risk of spontaneous bleeding is really eminent if counts go below 20, 10. So don't go there without doing something. The other differential, if a patient in labor, blah, blah, has a low platelet count, don't forget the other TMS, because TTP adult HUS, which call the atypical HUS, they too can present in pregnancy. So when you see thrombocytopenia, think broadly, not just that, oh, this is the HELP syndrome. It could actually be TTP. We know, and we talked about this, that the mechanism of thrombocytopenia here is a consumptive disorder. And generally speaking, platelet transfusions are contraindicated in consumptive disorders, including the TMS. So if somebody has got HUS, TTP, we don't start with platelet transfusion, and we know that. But the exceptions are that if it's a life-threatening bleed, we may have to transfuse platelets. And this also applies to PET patients. So Dr. Kim has talked about that platelet count of 50. So generally speaking, people think platelet counts of 50,000 and above, maybe not that be safe. Why do we think so? Because we think with that 50, you may actually get a very good primary hemostasis. Those counts are enough to achieve a very good primary hemostasis. However, when you have counts below 20 plus bleeding, then you may have to transfuse platelets immediately. So that is therapeutic. If you are planning the delivery, as my colleagues have talked about, counts below 30,000, if you are planning a vaginal birth, you may have to give a prophylactic platelet transfusion. And if you are going invasive, specifically going by cesarean section, counts below 50, prior to going in, you may have to give a platelet transfusion. Now, there is a caveat to that these thresholds, the evidence base is actually from patients, mothers with thrombocytopenia from ITP. ITP is a completely new disease entity. It is an immune-mediated thrombocytopenia. It may become chronic in adult. We see it quite common in children. So the diseases are quite different, but that's what people are talking about. So they are using thresholds for one disease entity and they are trying to apply it for PET. So try to be very conscious. So don't take this as gospel truth. So these thresholds, they are used, and this is the problem with evidence from elsewhere. You use it, no, the limitations. Generally speaking, after the delivery that we have talked about, the platelet counts return to normal by default. Normal meaning you're out of anything above 100,000. Plasma transfusions may be indicated if you get into DIC. We talked about doing the test and scoring to know who is in at risk of DIC. We know the role of plasma. Generally speaking, plasma transfusions have gradually reduced over because we have alternatives. But in DIC, it replaces the majority of the factors. So transfuse plasma when you have DIC. And in severe cases, you may actually have to give it as an exchange transfusion if you have the equipment. And in Uganda, we have an equipment, I think, at JCRC. Thank you.
Okay, this is something that we need to utilize more and more. And also give him a chance to talk about a lot of TMAs and so on. So, members, we are coming to close, so can be patient a little bit more. I now have the honor and privilege to introduce a senior consultant, obstetrician and gynecologist, a PhD fellow. Can this thing be prevented? Welcome.
Thank you, Dr. Misha and colleagues. I know most of the gurus in the topic have already talked, and nevertheless, we have to say something. I would say that just opening remarks, they have already said that the preeclampsia is among the big five. But in our institution, it is actually among the big two. PPH then comes. And we want to say that opening remarks that this preeclampsia and eclampsia requires multidisciplinary approach and the institutional readiness and rapid response team. I know they are talking about rapid response team for PPA, but you have to have that. Institutional readiness, what does it mean? Institutional readiness means you have things like BP or early diagnosis. You have things like drugs. We have talked about magnesium sulfate. We have talked about labetalol. We have talked about hydralazine. But are these drugs in the institution? Then early referrals. I know we get a lot from Kawempe. Maybe somebody can just say. So I was given to talk about the prognosis, but most of the things have been talked about, and the definitions. You can go to the next slide. That is also being talked about. This is coming after 20 weeks, new onset. Maybe just to say something small about what prognosis is. From epidemiology, what has the probable outcome or cause of the disease and the patient's chance of recovery. Is it a good chance? Is it excellent? Is it fair or poor? So you can go on that. So as we are doing prognosis, we have to know early diagnosis, early screening, very important. Most of these high-risk mothers can be good. So if you get these women early enough, and if you have taken their BP and the BP is high, then the prognosis will be fair. Then, of course, there are things we have talked about, having taken good history. If you get moms who are below 20 and those who are above 40 in the antenatal clinic, what do? They have high chances of having high risk. These days we are getting mothers who have done IVF. Most of these mothers will agree with me, present with preeclampsia or the complication. And most times where they are done, they are not sent early. They wait for the complication, then they send them. Of course, we are talking about chronic disease, gestational anemia, and all that. Taking BP, monitoring weight gain, I'll tell you that if people, they think that if you gain weight, especially if you're a woman, that means you are doing well. But when you put it and say, it might not be equal to that. It might be actually getting the disease. We have talked about this pre-existing. If you have a pre-existing condition, in addition to having preeclampsia, you have a DA, WSLE, then your prognosis actually might be poor. Then if you present with complications, which will pulmonary edema, liver injury, present convulsion and fits. In terms of convulsion and fits, is that if you get a mom referred, commonly we get from Kawel, they are not Dr. here. And so get a mom who has been fit, has fitted 3 times or 5 times in Kawel, and is referred to our hospital or any other benefit unit, then the outcome might be poor compared to a mom who has convulsed once. Because during that time of convulsion, then there is a brain hypoxia, there is less blood flow to the brain. And when you get things like a blood shock, health, and then acute kidney injury and neurological complications, commonly we get neurological complications of period, and then this mom is presented to us. Even when we deliver them, we need to get a neurophysician, and you know where we are working, we don't have physicians, and we have to depend on sister institutions to have them come and review the mom. If we get neurological conditions, then the other thing, commonly when you talk about prognosis, most times people think about moms, they don't think about it. But we are going to tell you that in the last quarter, in our women hospital, out of total admission in the world, 33 moms had either preeclampsia or eclampsia. So, and these ones were removed from term, weeks ranging from 24, 25, 26. And after delivery of these babies, when you follow them in NICU, most of these babies are done. So I know we are saying that, so we have to be very careful when we are planning delivery, because the outcomes of these babies, when you follow them, they actually, most of them have poor outcomes. So we have to do the investigations. We have to do the blood investigation. We have to do the neurological, the ultrasound investigations, and then follow this antenatal state of steroids. Still, if I forget from antenatal, I'm going to mention some things earlier than as per the slides. When do we give this now an update? When do we give aspirin? This mom prevention of either developing preeclampsia or severe. That has been enough. The current evidence shows that if aspirin is given the dose of 150 and should be given before 16 weeks. If you give aspirin before, after, then there is not much change, because controlled studies of moms were given before 16 weeks and after 16 weeks. Those who are given after 16 weeks, there was no change in maternal and neonatal outcomes. So, in terms, when we are looking at them in antenatal, that's what we consider. Then the gestational age will determine outcome prognosis for especially for the babies. Because we are having those babies who are between, especially remote from time. When should we deliver? When should we investigation should we do? How often should we do it? So this is very important. And we give the antenatal steroids. So we do the last, for those who are at risk in antenatal, we can do non-stress test. This stress test is not specific, but it can screen, it's like a screening tool. Then it can be non-reactive, or we can do a biophysical profile, like we saw in that patient. Then babies with fetal growth restriction and oligohydramnios. If you have already oligohydramnios, you don't know when to set because of placenta insufficiency. Then the prognosis is going to be poor for the baby because they may have hypoplastic lumps. Even if you deliver a good way, then they may have hypoplastic lumps and they may fail to breathe. We have those very low birth weight, as is indicated there, very low birth weight, and when you have below, having a bit below 1,000 grams or below 100 before 500. In our hospital, notice, of course, a different setting. Most we have babies surviving even 500 grams and below. But our further research has said that most of these babies develop cognitive problems later in life. So
the challenge comes when we say that this is the viability period. I know the Minister of Health is saying put in 26 for the country, but if you know that when you go up country, like Gabon, maybe you may not, in a center, you may not find any cure. So is it realistic? So that's a time to think about. Then other promotive factors which we consider is skills. Our health workers don't have good mental resuscitation. Ideally, every health provider who is engaged in delivery or in a maternity unit should be able to sustain a simple helping babies to breathe. And that's what we have been emphasizing. So if you have, health workers who don't know how to sustain, then you have issues. Then you have availability of medical services plus special care services is very important. I know that our sister institutions, they have NICU services, but usually they refer for NICU services. So I don't know what it means. We shall need to find them. In terms of prevention, it's a simple thing. How just diet? We know obesity is also associated with increased risk of this developing preeclampsia and other diseases. But there is a diet. What are we eating? What are we advising our mom to eat at dinner? We just have a lot of food there. Then exercise regularly. You know, we are talking about preeclampsia as if it's outside us, but we are involved in health workers. Ourselves are involved. Are we doing exercise? Are we having physiotherapy which is very active? I know it is another place 2 minutes, okay? Then checkups, talk smoking. I have 2 minutes, but I have to mention this one. Uterine local availability. We are doing only for and it's but evidence shows that we have to do uterine artery velocimetry because these changes start occurring early. And we have to do this between 16 weeks and 24. In a mom who is pregnant, there is uterine arteries and area of high resistance. So the picture which it shows a node. So if you see a node picture persisting in the uterine artery after 24 weeks, then we are in danger because the node should disappear by 20 weeks. I don't have the picture of the nodes. Then the other thing we're using nodules aspirin, I've already said that's one. We have to start it before 16 weeks. Then calcium and this calcium supplementation, we have to start it between 20 weeks because it inhibits endothelial reaction after it has been done. Already to drive vasoconstriction. Then the other one, when we stop with calcium will have to continue after the third trimester because the fetus actually requires this calcium for bone formation, skeletal formation. So the evidence is there that being a disease of symptoms and theories, no one knows exactly. So you may not have exactly what to prevent, but this aspirin and calcium supplementation are being shown to reduce the incidence and the risk, plus exercise and diet. I think that is all.
Thank you very much, Peter. One concept which the World Health Organization has been trying to implement for a long time, and they have not managed very well is the preconception care. but it's an aspect which maybe we ourselves need to take up and encourage our population to really embrace. In regard to time, we need to bring this to because we have some. We thought we would have a very short discussion unless there are very burning issues. We need to close. If there are burning issues, comments. But before I do that, the director, deputy director, Kawente National Referral Hospital, has been with us. You almost went last year, I said something, but of course, you may want to say 1 or 2 points, Dr. Lawrence Kazbe. What we would want, because with these academic things at times are not so useful unless they are put in practice, basically to serve the population, to help patients. And some of these we discuss, we see that they can actually be implemented. We've gone a long way in the way we manage patients, including having started all the way from the Magpie trial by was done also in Monaco here. So up to the current ones that are being done, the Dr. Namagen, you should be also being like this. So some of these have been done here and actually changing practice from those elephant mixture to magnesium sulfate. It was like a revolution. So we need to see how this can. Dr. Kaspo, without wasting time, we may want to greet members here, 1 or 2 words. Then we, there may even be other directors and we have not seen them. So, because we are talking about touching so much, the practice and care of patients. The one considering our time, you can greet members.
Thank you so much, Prof. Good evening, everyone. Mine is a vote of thanks to the people who have organized this round. It's been quite informative, and actually it will go a long way in helping us serve the clients in Kawempe better. I'm also adding my voice to the moderator, Prof. Biamgisha, the chair, that we wish to have more of these sessions. Some of these sessions brought closer home. Mr. Daban, I think I need to get your contact quickly because we have a little bit of issues here and there, but we need to get a little bit of more clarity. I remember, as you mentioned, especially the 2050 trillion parameter platelet count, and my small encounter with Prof. Yamgisha. I don't know if you remember the level 5. I wanted to talk to the patient who had the platelet count of 50 trillion. And he was telling me cautiously, go not quickly cut, but I ended up cutting it. I think all went well, and I did have more rapid. I'm glad that we have this opportunity. Those of us who attended today's session in Kawempe, you see what we want to impact knowledge and improve skills with basis for justification, mechanism of actions and all that. As I came in, Prof was mentioning a few things I was eagerly itching to hear, but I know they will come along as we continue having more of this organization, these ground rounds, scotomata, chiasma, optical blindness, several of the other injuries. I've shared some images. I'm on duty today in Kawempe, and I have this patient who has convulsed and all with an upper tongue and all that kind of thing. We have these patients with petechiae. We have all the varieties there are. But what is missing in there is at times the way we are doing our black sheep with no justification. We don't see you implementing plans of management or suggesting plans of management and even following up on implementing these. We SHOs, we undergraduates and the public interns. Can we try to get this message, this information put down on the, actually what the professor said, practice what we've learned, and then we have proper justification what we are doing. Litigation is on the rise. What we have not said is that we are also being called upon to offer expertise opinion to some of our colleagues. So take this session seriously. Let's practice with evidence like we've been taught, and all will be well. I thank you very much.
We are now certain that our patients are going to benefit and be managed better. So are there any burning questions or comments Addition is the experiences, we know how many experiences with the preeclamptic and eclamptic patients, and some of them at times are not very good. Yeah, but if there are comments there, you have a patient whom you've been managing for preeclampsia. You come to review her, you find that she's in a pool of blood. What is the right diagnosis? Yeah, let's have some comments. There must be some comments online. It could be. Then members put some of these things bluntly. It is said that the more fits a patient gets, the closer she gets to the grave. So we must always ensure that we minimize these fits and conditions. So as we do this, we need to have later we'll go to the closing ceremony where we'll have the Dean School of Medicine who is still with us. We prepare to give us some few remarks, and we'll have somebody who has assisted in the support, the refreshments and so on. See global health, there must be a representative.
So most of the questions have been answered along the Zoom responses. But then there are 2 hands online, and then there's one question that has repeatedly been asked. And that is the question on management. Is there a role of typhoid, also known as L-arginine, in the management of preeclampsia? That's the one which has been repeatedly asked without any response. And then we have 2, Dr. Kadroma, I think you answer on that. Then we have 2 hands online. That's the answer. There is a Twino West. Would you go ahead with your question?
Twino West, and then after that we have Babutunga Chelsea. Maybe we'll accept 2. There you go. Twino West, are you there? Oh, the hand has changed. And Charles Babutunga. We will just give you a few seconds. If you don't get on, then we move. Adroma, meanwhile, you can prepare to answer that question. Okay.
I think some students will have written papers.
Some of you are questions. Don't hesitate to send them over. Yes, bro.
Sorry, I received a question on my case. Just answer. That means Professor Chimu. One man get preeclampsia in one pregnancy, and maybe in another pregnancy in the same month. Yes.
Yes.
And we can even try and explain why this is the possibility in the logic. The fetus inherits one of the father's genomes and one of the mother's. So it is possible that one pregnancy, the father donates a good gene, and on another one, he donates the other one. So that is the right explanation. But also, I want, it is not possible, but we want people to, that's why we insist every pregnant woman is at risk. Sometimes women who have this preeclampsia and have private pregnancy, now is all well. But it is not. So every pregnancy, just know you're at risk. And actually, colleagues who have worked with us in Morocco for a long time, and we lost a colleague who have both pregnancy and obstetrician who are never preeclampsia. So this disease doesn't even feel obstetrician. So we should have pure high alert. Thank you.
Adroma, could you go ahead and answer the question?
Okay, thank you for that question. You know, as I said, we practice what we call evidence-based medicine. And what we present here is what has been tried and found to be either safe to the mother and to the baby, or okay, both safe to the mother and the baby, and also it gives you the outcome that you're looking for. So as far as we are concerned, we do not have much evidence of how L-arginine can either improve outcomes of pregnancy, both to the mother and to the baby. But as the theory says, these are all suggestions that we do not really have much information to say yes or no. Until an evidence comes up and says that this is safe to use and it's effective, for now we use. Maybe a cool year.
I'm not really adding, but just so this question keeps coming up, but we do not do things which will even be harmful for our patients. For example, there are even some people who are trying to give natural killer cell treatment so that the women can have old remodeling. And this is happening in America, of all places where things should be tightly regulated. So a lot of things are being given to mothers. There are a lot of potential and promising therapies, but for now the evidence is not strong enough to warrant us using them. For example, selenium is one of those that as a micronutrient. So let's be on the lookout. And if you have questions or you hear of things, let us know, and then we can go ahead and conduct clinical trials to get the necessary.
Thank you very much. And many things have been added. Some people have tried supplements, vitamin C, D. Some of them are like in areas where there is deficiency of calcium and so. And when you look at some of these, many of them have been answered maybe for purposes of sharing. See the role of aspirin in prevention and recurrence. We have a link to the current guidelines. The team here should be able to really share. So a number of questions have already been addressed. We thought we would give somebody online one, but they are not talking. Any other? Yes, please.
We also have a suggestion that as the Pre-Eclampsia Committee, we get all these questions, whether answered or not. We write the answers briefly and circulate this document widely.
Yeah.
Because we know that this time can't allow us to really respond.
Yes, that's right.
Like we have been doing for other webinars.
Members, I hope you have heard that. Preeclampsia. The questions can be sent to the team and they address them, and they will share answers on a wider basis. Nitric oxide has been tried as well, but they say evidence doesn't show that it is very useful, and it is linked with the arginine, if you remember those cycles. Okay, we should bring this to close. Yes, so maybe let me first thank you very much, members who have remained, who have stayed and are here physically, and those who are online. And thanks for the active participation. Okay. I think we need to clap for ourselves. One of us must have been some new word or some new method of treatment and so on. That's here we keep adding, the relative is cumulative. So let's get a representative from Gynecology. Please come and give us 1 or 2 words before we call on Professor Nachi to do the overall closing. That is the process. Yes, please.
Thank you so much. Students for attending our leaders in different capacities, protocol observed. Good evening, ladies and gentlemen. My name is Chris Nakatite, Bishop, Bishop Nakatite,
I'm working with City Global Health as a program officer, and I'm here representing the country director who is not able to be with us. I'm engaged in a different activity with our global team. We are so grateful for the team, for what you've done, the team led by Dr. Nationally and colleagues. People, it's real out there that we don't know about eclampsia or preeclampsia, even after learning about it. Because we get deterred from the reality by what happens in communities. People are going through this situation and they are facing preeclampsia, even when they don't know that they are going through it. There are many survivors of preeclampsia who don't know that they are even survivors of this. I am very sure many of us here, like 50%, if we didn't get this information and get a similar situation back in the field or in the villages, we would put it on the mother-in-law, the co-wife, the ex-girlfriend of our husbands that did ABC because they didn't want you to deliver. But it's really, really happening. City Global Health's main goal is to enable access to high quality emergency care and maternal, newborn, and child health services. When you look at preeclampsia, it falls under like two. It can be an emergency case, as we've seen from the different presenters, and it also contributes to the maternal and child. I was telling Dr. Carol last time when we were in Bali for the same activity in the ground round, that I suffered preeclampsia on my first pregnancy. I carried twins at an early age, and I had mixed feelings. I was happy, I was anxious, I didn't know what to do, and I didn't want to tell my then boyfriend, not a husband by then. But then, when I was 35 weeks, and I was told I have preeclampsia, I started reading about it. I was prepared. I had a chance that I was prepared. But the fact that it was something scary every time I read about it, the condition just worsened. Because everything you're reading about it is bad. So the condition just worsened. And I was prepared for an early delivery at 37 weeks. Vis-a-vis, one of my friends had a similar condition, but for her, she refused to accept that it was preeclampsia. She didn't have much information about it. And she ended up saying it is the ex-wife of the husband who did something and she failed to deliver normally. So why am I saying this is information is not yet there about the condition. Let's do our best as we've learned and as we continue learning to also sensitize others to pass on this knowledge so that we prevent preeclampsia at least where we can. I won't say so much because time is not on our side, but I see Global Health, we are very happy to partner with Makerere University, and we are very glad to partner with this department specifically, and we've pledged to continue partnering. Yesterday we were with Dr. Olaro, and was like, we wish we can have round rounds in different topics, at least every 2 months or every quarter.
Every 2 weeks.
We shall not, every 2 weeks. We shall not pledge right now, but we are going in a phase of planning, and there is a project up there that if it all goes well, City Global Health will be able to work with the team on ground here, make sure we have the very important topics discussed in ground rounds at least once in a quarter. So thank you so much.
Thank you very much. Send our regards to Management Council Global Health. So members, let us thank the people who presented, actively represented from the beginning, Charles Segala, Pisa Lupa, Professor Chirono. Our chair, thank you very much. Members, done an excellent job. Of course, at Roma was our sister, thank you very much. With you, Vita Julio. So you have the people just say HE, they don't even mention the name. But His Excellency usually delegates the Minister of Education and Sports. As far as we are concerned here, the Minister of Education and Sports, the delegates, if you look at Makerere University, of course, the chancellor that knows so, the vice chancellor. But now when you come to the college here, for example, you have the principal. Principal has dean. So now here we have a dean, School of Medicine. So basically, when it comes to this is representing all those.
Ladies and gentlemen, I'm aware that we've had a long afternoon, but so quick. It's my pleasure as Dean School of Medicine to first of all participated in this grand round, and more importantly, in a special way, I want to thank the Department of Obstetrics and Gynecology. I don't have that. It's very important background. As you heard, we are dealing with the big two, preeclampsia and PPH. But actually, we know that in most of the big hospitals, preeclampsia is really taking over from PPH. Now, of course, I can't forget to thank Seed Global Health for sponsoring this grand round and all the others around the campus. Month of May has been Preeclampsia Awareness Month, and this grand round has been a grand finale to that. So, it doesn't mean that we are stopping the awareness activities today, as we've had the demand for knowledge for skills is great. We plan to continue as the NASMEC Committee of Preeclampsia to carry out more regular updates so that members remain clearly informed, not just this one big dose will be the new. We consider this a growing dose. Yeah, so Seed Global is actually a very big stakeholder in the School of Medicine. They are one of the major sponsors of our Master of Medicine in Emergency, our Master's program in Emergency Medicine. A young program, and we expect the first graduates next year. So thank you very much. So they are really with us all the way, not just for these grand rounds, but also ensuring that emergency medicine takes root in the university. We have to thank the chair. You may forget. Professor Eclampsia is director of Makerere University Hospitals. Former chair of the Gynecology department. You know, in other words, we don't fight over the head. We hand over peacefully. So he handed over to me peacefully, and I handed to Musa peacefully. So I think the panelists have done a great job to give them a round of applause. grand round, you had to be really balanced well. We know the grand rounds are generally academic, but we were aware that part of the online audience is lay. So it was important that the messages are both, have a blend of academia and for the community. So we hope we have achieved that. But most importantly, I want to emphasize that we shall go on to try and respond to the question. I think to be a good idea to have both the doctor's version and then that for a lay person, so that they're able to appreciate these issues. I want to bring you to at least inform you that we are here because of the Department of Health and Life, but there's been a lot of input from the Ministry of Health through the National Safe Motherhood Committee, which we call NASMEC, the Pre-Eclampsia Subcommittee. I chair that, and I must say a lot of work is being done by the national-wide champions. We have champions in every corner of the country. We are over 100 pre-eclampsia champions. Dr. Jacqueline Makelo, I don't know what she's always right and she's the coordinator of the committee, national coordinator, based all the way at Lepi Hospital as the medical superintendent, but practicing there as well. Andrew to remember spoke. I've been behind the scenes trying to make sure this ground really succeeds. And we are aware that the online audience has been which is really a sign of good mobilization. And our team has a lot of midwives. You had the important role midwives play in getting this problem sorted. Thank you, Sister Labuku, in a special way. For a long time, she headed the pre-eclampsia unit in Kawepe, and before that, and continues to do a lot of work from the committee. By the way, I want to correct, I think the impression is not that Kawepe is not handling mothers well. We need to re-upload them. I know Dr. Kasiwe has left. It is the unit that manages the most number of pre-eclampsia in the world. But also probably many are succumbing. So we are trying a lot to make sure that the care there improves, but we really acknowledge the great work coming from Kawepe and also the great work coming from Women's Hospital. I know Dr. Tuyo is here, head of MFM, from maternal medicine at Women's Hospital. Thank you for looking after our men, especially the referrals. And don't complain when we refer for NICU. So there we have, as a committee, participated in the revision of the clinical guidelines and protocols for maternal and newborn care. It is everybody in this room should have access to that as a soft copy or a hard copy, because you need it. All these things we have included, and they are good for you as a practitioner. Now, I think there's something Michael has talked about. We have to know that the business of preeclampsia doesn't end in the postnatal clinic. The disease is so bad, or to say so mean, that even when women recover from it, usually about 3 months, the majority, we are seeing that actually over like 28% after 1 year remain hypertensive. But also, those who recover within 3 months, many a few years later, usually 5 onwards, they now develop full-blown chronic hypertension, cardiovascular disease, renal disease. So we are yet to see really a full wrap of the disease in this setting, but we are trying to do a lot of work on this. And already we are seeing that many of our women in Kawepe actually come back a year later, 2 years later, with cardiovascular disease or hypertension. So we have to make sure that women maintain a healthy lifestyle so that they will keep the non-communicable diseases away. Now, I could go on and on, but I now need to, first of all, thank you very much for being patient. The online audience, I know it's still with us, for your patience. And to say that this is just the beginning of the fight against preeclampsia. And as we continue with this fight, please join us, because I think it requires a lot of strategies, both ordinary and the guerrilla warfare. So thank you for coming, and it's my pleasure to be there, the closure of this one round.